Yes, sir, we are good to go.
Okay, thank you. So, a very good evening, everyone. Welcome to the 8th edition of ISPAE Postgraduate Endocrinology Program Series. So, I will request Ahilya Ma'am, President ISPAE, to say a few words, followed by Professor Abhipati sir, who is Advisor ISPAE, and the motivation behind this PEP program to introduce PEP and its aims. Ahilya Ma'am, please.
Evening, everyone. It's a pleasure to see all of you here at the Pediatric Endocrinology for Postgraduates. As Dr. Jaivinder had mentioned, it's a brainchild of Professor Abhipati, and I'm sure all the postgraduates are going to benefit enormously. And this session is especially special with a lot of doyens here, including Dr. Vaman Kadalkar, Dr. Anurag Bajpai, and a wonderful case presentation by Dr. Deeksha under the stewardship of Dr. Atul Gupta. And it's nice to see a wonderful panel, and also best wishes to both Dr. Amarnath and Dr. Jaivinder for this wonderful efforts. Best wishes and welcome to the program. Thanks.
Thank you. Raghupati sir, please, for the introduction and aims of this program.
Dear friends, this program on pediatric endocrinology for postgraduates was a long felt need, and I'm glad we started it off in Bangalore and then had it one after the other in different states. And I remember Dr. Anurag and Dr. Vaman were regular speakers in these meetings. And now I am glad to see that it has grown to 3 monthly meetings. We always used to have these meetings just before the MD exam in various universities or the DNB exam. And today I was wondering whether there were no exams nearby and whether the attendance was low because of that. And it might be the reason for some at least. And as the exams come near, the tension grows up. And then especially endocrinology, there's nobody to teach in many of the medical colleges or even the private institutions. And at that time, the number will definitely increase. So it's quite simple, but we have been able to conduct this quite regularly, thanks to Amarnath, who goes after people, untiringly. And we get so many emails and WhatsApp messages and so on. And we must really thank you, Amarnath, for your enthusiasm. And without further ado, I think we'll start with the program as we have a crowded program today. Thank you.
Thank you, sir, for the nice introduction. So we will be starting with the first part of the program. So first part is lecture on growth charts and bone age assessment by Dr. Vaman Kadalkar. And it's my honor to introduce sir. And everybody knows sir. Sir needs no introduction. He is a doyen in pediatric endocrinology, and all of us have used the charts developed by him for growth monitoring in all of our children. So sir is a senior pediatric and adolescent endocrinologist at Jahangir Hospital, Pune. He is PhD guide for the Health Sciences Department, Pune University, Pune, and he is convener of Obesity Guidelines Committee of Central IIP 2023. He has been the convener for the Growth Charts Committee in years 2007, 2010, 2014, convener for calcium and vitamin D deficiency. Sir has numerous publications to his name and has written many chapters. And he's the editor for the IIP textbook of endocrinology. Sir, please deliver your lecture.
Thank you. First of all, I would like to thank ISPAE for this wonderful initiative. Would like to thank Dr. Ahilya, Dr. Raghupati sir, Dr. Jaivinder, and Amarnath for his tireless efforts. Without wasting any further time, I would like to start my lecture. So I would like to share my screen now. So I hope you all can see my screen.
Yes, sir. Yes, sir. The screen is visible.
Now, because this lecture is meant for postgraduates in pediatrics, I am going to start with very basics, and then hopefully we'll be able to build on some of the newer concepts in growth charts and bone age. So first question that is always asked is, why should we monitor growth in children? What is the need to monitor growth? Or why is this important thing being part of the child health surveillance? So remember that children's growth monitoring is essential part of child health surveillance. Most of the red books that you see in the developed part of the world, which is like a baby book, that has first few pages only as growth charts. And it has been shown for more than a century now that growth monitoring alone has been shown to improve children's health, reduce mortality, as well as morbidity across the world. And for people who perhaps may not have seen the book by Professor David Morley, which was very popular about 50 years ago, it is called The Pediatric Priorities in the Developing World, is the first book that mentions the importance of growth monitoring. And it also introduces the concept of parent-held growth charts. So growth chart is also, as you know, known to road to health chart. So as long as a baby is following between the normal tram lines for height, weight, weight for height and BMI, then the baby is following a road to health. What parameters do we follow and how often should we monitor a child? Are there any guidelines for this? Are there any Indian guidelines? The answer to this question is yes. Indian Academy of Pediatrics wrote growth monitoring guidelines for children in 2007. And you can find this on the web or on Indian Pediatrics website. They are IIP growth monitoring guidelines for children from birth to 18 years of age. But generally, in a nutshell, this is what is recommended by the guideline, when and what to monitor. So the interval for children under 3 years of age, at birth, 6, 10, 14 weeks, 9 months, and 12 to 15 months, that is taking opportunity at immunization visits. Additional timings, 6 months, and opportunistic measurement at each visit for any other sickness. What parameters do you measure? You measure the weight, height or length, and head circumference. For older children between 4 to 18 years, should be monitored 3 monthly, and what you monitor is the height, weight, and body mass index. Now, the equivalent of body mass index in younger children is weight for length, and I would be talking further on that after a couple of slides. Now, the common question asked in the PG examination or in theory examination is, what growth charts do we use for India? Now, Indian Academy of Pediatrics recommends IIP revised growth charts 2015 for children who are 5 to 18-year-old. But both IIP and Government of India have recommended to use WHO growth charts for children under the age of 5 years. And IIP has simplified these growth charts for everyday use. Now let's understand the basics of growth charts. As you know, growth charts are graphical designs of percentiles across ages. So on your x-axis, you have the age either in months or in years. For younger children, WHO has produced growth charts which are in months, so from 0 to 60 months. And on the y-axis, IIP has combined all three parameters together. So there is length or height, there is head circumference, and there is weight. On the flip side of the chart, you have weight for length chart. In younger children, please remember, we do not use BMI, we use weight for height. For pediatric trainees, it is also important to remember that weight for height is an age-independent criterion. And in many countries in the world where date of birth or age is not exactly known, an age-independent criterion becomes very useful in diagnosing children with various grades of malnutrition. So weight for length is an age-independent criterion, and the chart which is seen on the screen on the right side is weight for length or height chart. But what do the lines depict? Now, these are the IAP modified simple WHO charts, where you can see that the blue arrow is the average line, which is 50th percentile or 0 Z-score. The top line is the 97th percentile or +2 Z-score, which is the upper limit of normal. And the orange arrow is the 3rd percentile or -2 Z-score. Now, I often see postgraduates making a mistake between the 3rd percentile and the -3 Z-score. But please get this right, that 3rd percentile is -2 Z-score, and -3 Z-score is actually the first or 0.1st percentile. So the top line is the upper limit of normal, the blue arrow middle line is the average, orange arrow is the -2 Z-score, which is the lower limit of normal, and -3 Z-score is very abnormal, very abnormal. If you look at the WHO growth charts, you will also see lines at 10th percentile, 25th percentile, 75th percentile, 90th percentile. But the reason why IAP kept it simple, because we did not want to clutter the growth chart, so plotting becomes easier. Now, similarly for weight for length chart, the lines are slightly different. The average line remains 0. -2 Z-score remains the 3rd percentile. -3 Z-score is the 1st percentile. But what you must look at is the top percentile shown here is the 99th or the +3 Z-score line. So in very young children, WHO actually makes allowances for slightly chubbier babies to be normal. To diagnose obesity at such a young age, the weight for length should be more than +3 Z-score and not like +1 for overweight and +2 for obesity on regular WHO growth chart for older children. For younger children, the limit is +3. Similarly, for growth charts in older children, these are the IAP growth charts for 5 to 15 years. And you again see the same 3 lines, the average, the +2 Z-score, the -2 Z-score for height. And on these charts, you have all other percentiles, 10th, 25th, 75th, 90th. Similarly, for weight, there is -2 Z-score, which is the 3rd percentile, 0 Z-score is the 50th, and 97th percentile is +2. And you again have the 90th, 75th, 25th, and 10th percentile lines. Now, some of you might have noticed that while the height percentile lines are equidistant, the weight are not. Now, why is that? Because height is a normally distributed variable in the sense that it follows the Gaussian distribution, whereas weight is always skewed to the right. So the upper percentiles are always wider for both weight as well as body mass index. So moving on to the body mass index charts. Now these charts are Asian specific, designed by the Indian Academy of Pediatrics with different cutoffs for overweight and obesity. And I would like the postgraduates who are listening to this lecture to be very careful in understanding this chart. If you go to the WHO BMI charts, the overweight line is the 25th adult equivalent or +1 Z-score. In WHO growth charts, the obesity line is +2 Z-score or adult equivalent of 30. However, for Indian people, there is a higher risk of metabolic syndrome at a lower BMI. And therefore, WHO and International Obesity Task Force actually recommends lower cutoff for Asian Indians. Hence, the IAP growth charts have 23 adult equivalent line as overweight and 27th adult equivalent line for obesity. And anybody below the 3rd percentile on BMI is considered as underweight for older children. Now, how do you plot a growth chart as a postgraduate? You must take the length or height, weight, and head circumference. There are only 4 lines, as I mentioned, on the IIP growth chart. They are either expressed as z-scores or percentiles of both. And you have to just put a dot. Don't make a circle or targets around that dot. So the graph has been divided as vertical grade and horizontal grade. Horizontally, each line represents either a centimeter or a kilo. And vertically, each line presents a week, 1 week, or 15 days as the dark line. So let's take an example of a 3-year-old boy whose length is 95 and weight is 15 kilos and head circumference is 48. So this is how your plotted chart will look, the IIP WHO modified chart. This is the length, this is the head circumference, and this is the weight. Whereas when you plot on the flip side of the chart, which is weight for length chart, this child's weight for the given length falls between the 50th and the 99th percentile. So this baby is normal in terms of his weight for length, or his nutritional status is normal. Now the next concept of growth charts is calculating the genetic potential or the mid-parental height, also known as the target height. Now the formula for using target height is mother's height plus father's height plus 15, plus 13 divided by 2 for boys, and mother's height plus father's height minus 13 divided by 2 for girls. Now, why do you subtract 13? The reason that is done is because the average difference between an adult man and a woman is 13 centimeters. Hence, that 13 number comes here. Now, this target height is to be plotted at 18 years of age on the growth chart. And the target range is between 6 to 9 centimeter, depending on whether you follow plus 1.5% SD or plus 2 SD as the normal deviation within the family kindreds. But please remember that most of the charts in the world now take it as 6 centimeters, 1.5 SD rather than 2 SD, as often mentioned in your textbooks. So this is how you plot the target height, and this is the target. The target height is 164, and the range by subtracting and adding 6 centimeters on both sides will be 158 to 170 centimeters. Now there is something called as adjusted mid-parental height. Now what is that? The purists say that this formula doesn't give you the correct height. So the better way of calculating accurate mid-parental height is to calculate father's height standard deviation score, mother's height standard deviation score, and divide those by 2. Also, in a country like India, where the secular trend in certain parts is prominent, how do you correct for secular trend in mid-parental height? This is known as conditional mid-parental or target height. This is particularly useful when you are looking at a family of people which is either too short or too tall. So you are likely to either overestimate or underestimate the genetic potential of the child. Correcting this bit is known as the conditional MPH, and that is calculated by target height standard deviation score multiplied by 0.72. So you have a correction factor of 0.72 that narrows the gap in very short and very tall people. And how do you correct for secular trend? This formula will correct for secular trend, provided that the parents' Z scores are calculated based on the growth charts used for their generation. So growth charts which were in vogue 20 years, 30 years ago should be used for calculating the Z score for parents' heights. Now, I have already shown you the one example of how to plot mid-parental height. Now, here you see that you have a 9-year-old boy whose height is 119 centimeters, and he is actually on the 3rd percentile of the IAP chart. His father is 157 and mother is 150, so short family. So your target range is 154 to 166 as plotted here. And when you correct for his genetic potential, now you can see that although this child is on the 3rd percentile or just below the 3rd percentile, he falls well within the family range. So this is a normal child for that particular family. That is the advantage of taking parents' height and calculating mid-parental height. Next is, how do you calculate body mass index? It's a simple formula where you take weight in kilograms divided by height in meters squared. Now, from what age can you use BMI? You should start using BMI from the age of 5 years onwards. I have already mentioned about these charts. Use them for children who are older than 5 years. For younger children, as mentioned earlier, you use weight for length charts. And here the cutoff line is much higher because WHO makes allowances for babies to be a little chubbier at younger age. So you have the 99th percentile of WHO weight for length chart as a cutoff for obesity. Now, as you saw, the body mass index calculation as well as the MPH calculations are a bit cumbersome, and not all doctors are very good mathematicians. So is there a simpler way of doing it? So Indian Academy of Pediatrics has given pediatrician-friendly growth charts as shown here, and there are new tools inserted into the standard charts. Here on the left-hand side, what you see is a quick body mass index lookup tool applicable for children between 8 to 18 years. And on the right side of the graph, you have a mid-parental height calculator, a quick lookup tool for MPH. How do you employ this? I'll show you in a minute. So this is the blown up picture of your weight for height BMI lookup tool. So instead of calculating the BMI, you just look up the height of the child and the weight of the child. And now let's take some examples. Suppose you have a child, a girl whose height is 135 and weight is 30. Then she falls in the normal range. If the same height girl has a weight of 35, she falls in the overweight. Girl of the same height with a weight of 45 falls in the obesity range, and a girl with a weight of 20 with the same height falls in the underweight. So here is a quick lookup tool that shows you how without calculation on the growth chart itself, you can see what is the nutritional status of a child between the age of 8 to 18 years. For younger children, this tool is not applicable. But as you probably know by now, obesity starts becoming a major menace in pediatrics, mainly after the age of 8 years or around puberty. Similarly, for mid-parental height, now there's a simple tool. You just plot the father's height on this side and the mother's height on the right side and join the two by this line. And in the middle, you have the mid-parental height percentile scale. So in this particular child, the mid-parental height is between 25th and 50th, closer to the 50th percentile. So that simplifies your calculations. Now, many of you see a lot of very, very small preterm children, and you always wonder what charts you should use. Now, I'm sure there are many institutes in India still which end up using Fenton's charts or some other charts. But please remember, now in this day and age, for plotting growth of preterm children, please use Intergrowth 21 charts. They're easily available to download from web, And the reason why we recommend using them is because as the children come to term, they amalgamate perfectly well with the WHO 2006 MGRS standards. So instead of using Fenton charts, the recommendation now is to use Intergrowth 21 chart for preterm boys and preterm girls. Now, what are the nutritional cutoffs that are recommended? Now, you can read this off this table that for children under the age of 5 years, the terminologies are underweight, severe underweight, stunted, severe stunted, wasted, and severe wasted. And here you can see that the indicator is weight for age for underweight and severe underweight, length for age for stunting and severe stunting. For wasting and severe wasting, it is weight for height, not BMI, weight for height. Whereas in older children, the upper two parameters remain the same, but for overweight and obesity, it is BMI, and your cutoff is 23rd adult equivalent for overweight and 27th adult equivalent for obesity. The same has been translated into Z-scores and percentile in the columns on your right-hand side. Now, what other parameters in terms of growth charts can we assess in children? Now, height velocity is a very important parameter when it comes to looking after a short child. And the way a height velocity is calculated is delta height upon delta time. What it means, change in the height over a period of change in time. For example, let's take this example of a boy who is 120 centimeters at 9.5 years, and then he becomes 124 centimeters at 10.5 years. So in 1 year, he has grown 4 centimeters. So we plot him between these 2%, between these two times, which is 9.5 and 10.5 years. So at 10 years, you plot his height velocity at 4 centimeters. And here you can see his height velocity is actually below the 25th percentile line. So this is abnormal height velocity. This is a low height velocity. Please remember that in height chart, the cutoff is 3rd percentile, whereas in height velocity chart, the cutoff line is 25 percentile because it's a dynamic process. So a child who grows 4 centimeters in a year is abnormal on the velocity charts. These are Indian height velocity charts. The original height velocity charts came from Professor J.M. Tanner in England. But in India, we have a slightly different pattern. You will find the charts published in Indian Pediatrics. For postgraduates, simply to remember, in the first year, the child grows 24 centimeters. In the second year, 12 centimeters. In the third year, 6 centimeters. And from then until puberty, 5 centimeters per year. And during puberty, if it's a girl, she grows about 7 to 9 centimeters. And for a boy, it's between 8 to 10 centimeters, sometimes as much as 12 centimeters. Now, childhood obesity, as you know, is a major problem all over the world and in India. So for obesity, we must measure some more parameters. And as you know, metabolic syndrome is now being defined in children who are older than 8 years or who are in puberty with these criteria. And if you look at the first criterion, it is the waist circumference, which is appropriate for ethnicity and the age of the child. And therefore, you must get into now habit of measuring the waist circumference in Indian children. And we now have Indian waist circumference published in the American Journal of Pediatrics, and they are available from this paper. And we recommend 70th percentile as a cutoff for screening children with metabolic syndrome. So remember that you should have ethnic references, which we have now. And the recommendation for metabolic syndrome is 90th percentile for these weight charts, for these waist circumference charts. However, in our study, we have started seeing metabolic abnormality from 70th percentile onwards itself. Now, the next thing is when you come across a short child, you must look at the proportions. So we now have proportion chart available. If you have an achondroplastic child like this, then look at the proportions. We now have upper body, lower body segments published for Indian children, as well as sitting height percentile for Indian children. These charts are available, but what is important to remember as a postgraduate is that unless the discrepancy between the upper segment and the lower segment is more than 2 standard deviation or 3 major lines on these charts, that disproportion is not significant. So to have a significant disproportion, there should be a discrepancy of more than 2 standard deviation between the upper segment and the lower segment. Then there are extended IIP growth charts which also depict 3 other lines: minus 2.2 standard deviation score, minus 2.5 standard deviation score, and minus 3 standard deviation score. And these cutoff lines are specific for disease: minus 2.2 for idiopathic short stature, minus 2.5 for small for gestational age babies who failed to catch up, and minus 3 for profound or severe short stature. Now, as a postgraduate, you must understand this concept: is how far below the 3rd percentile is my patient. If it is just below the 3rd percentile, you are looking at a group of disorder which constitute a familial or idiopathic short stature, constitutional delay in growth and puberty, chronic systemic disease, small for gestational age babies, or chronic malnutrition. Whereas if it is way below like this, really profound short child, then it's a skeletal dysplasia, a syndrome, an endocrine disorder, a bone disease, or a very severe chronic disease such as chronic renal failure. Now, disease-specific growth charts are available, and you must be aware that there are Down syndrome charts, there are Turner syndrome charts, and we recommend to use disease-specific charts for children who have that specific disorder. Now, the concept of height age, weight age, and bone age. Now, here we introduce the concept of height age and weight age. So, if this is where the child's height is, then you draw a line parallel until it reaches the 50th percentile, and then drop a perpendicular arrow like this until it reaches the age or the x-axis. So, in this particular child, as you can see, the height age is 6 years, whereas the weight age is much lower, 4.5 years. So when you have weight age less than the height age and both are low, it's chronic systemic disease or chronic malnutrition. Whereas here is another girl who has more height deficit than weight deficit. Her height age is actually 5.6 years, whereas her weight age is 6.6 years. So more preservation of weight as compared to the height. So this short child has relative preservation of weight. So she either has a skeletal dysplasia or a syndromic short stature or an endocrine disease such as hypothyroidism. Now here is a boy who is much too tall with a height age of 9.5 years and a weight age of 6.6 years. So his height age is maximum, followed by weight age, followed by chronological age. So this is true precocious puberty. So as you can see in the box here on your right hand side, when the chronological age is greater than height age, greater than bone age, greater than weight age, is nutritional deprivation or chronic systemic disease. If the chronological age is greater than weight age, greater than height age, greater than bone age, it's endocrine disease. If bone age is greater than height age, greater than weight age, greater than chronological age, it's precocious puberty. Weight age highest, followed by chronological age, followed by height age, followed by bone age, endocrine obesity. And weight age greater than height age, greater than bone age, greater than chronological age is simple or exogenous obesity. So just analyzing the height age, weight age, chronological age, and bone age you can largely tell what disease pattern you're looking at. That's the power of plotting growth charts and analyzing it properly. So this was an algorithm on how to monitor a child. I'm not going to go through this in the interest of time. I'll now quickly jump on to some basic concept of bone age, and we'll stop at that. Are there any software tools for your growth monitoring? Yes, this is the IIP growth chart application that you can download and use. It will plot the growth charts for you, as well as the new application which is being developed will also calculate the Z scores for you. Similarly, All India Institute of Medical Sciences have developed AnthroCal application, which is based on IIP as well as WHO, and it gives you Z scores for both. So for a given patient, it plots the chart and it gives you Z score for WHO as well as for IIP. Now bone age. Last few slides on bone age. What does bone age tell you? It tells you about the skeletal maturity. It correlates closely with skeletal maturity. It speaks of the remaining growth potential. So looking at the bone age X-ray, you can't tell how tall the child is, but you can tell how tall the child will be. So you predict the adult height using bone age. And in normal children, the bone age is within 10% or 1 standard deviation of the chronological age. Now, what are the factors which affect bone age? Nutrition and body mass index, stage of sexual maturity, certain hormones, and genetic factors. These 4 things largely determine the skeletal age of a child. Now, as I said, generally the bone age is about 10% around the chronological age. But in practical terms, for younger children who are less than, say, 6 years, bone age is within 1 year of the chronological age. And for older children, it is within 2 years of the chronological age. Clinically or practically, how do you plot bone age? You have seen some graphs where I showed you the height age, weight age calculation. Now, here is a 10-year-old girl whose height is 110, weight is 22. So her height age is 5.5, weight age is 7.4. So here you know that weight is preserved in the short child, so it must be a hormonal disease. Now you did a bone age, which is only 5 years. So you plot the bone age by putting a cross at 5 years. Thus, your formula now becomes chronological age greater than weight age greater than height age. So this is a syndromic obesity, or this is hypothyroidism. And in this child, the TSH was well over 100. So this is hypothyroidism. Now, the general theme of bone age maturation is like this. In infancy, you look at the carpal bones and the radius. Then in toddler, you look at the epiphysis of the metacarpals and proximal phalanges. In pre-puberty, you look at the size and width of the middle and distal phalanges. In mid and late puberty, you look at the size, the width, and the degree of epiphyseal fusion in these bones. And post-puberty, again, go back to your radius and ulna. What are the methods of bone age assessment? The traditional age-old, most well-practiced method is Grulich-Pile, which is a pattern matching. So if you have a patient who is 11-year-old, like here in the middle, you take out the atlas and you see whether it matches. Now here you can see that the atlas bones are more mature than this. So you then look at 1 year earlier, like 10-year-old. And here you see that your patient's bones are a little more mature than 10, but less mature than 11. So you can then say that my patient's bone age is between 10 and 11, somewhere around 10 and a half. Whereas other more complicated method that pediatric endocrinologists use is called Tanner-Whitehouse method, where you study these 13 different bones separately. And I'm not going to go through the details of this because it is really not for the postgraduates in pediatrics. If you look at the merits and demerits of the 3 methods, Tanner-Whitehouse 3 is perhaps the most accurate and most updated method of all three. Now, in the modern times, bone expert has come to India as well as has come to many parts of the world. This is a digital automated system that removes the error, which is the person error or the subjective error. So it's an objective assessment of the digital image and is supposed to be most precise, and it actually calculates using both methods, Grulich and Pyle as well as Tanner-Whitehouse. Now, what are the situations in which your bone age is not reliable? In skeletal dysplasias, it's not reliable. In babies who are short born SGA, it is not reliable. Syndromic children, it's not reliable. And in chronic systemic disease, especially in CKD, etc., it's not reliable because there is renal osteodystrophy that changes the pattern of bones. So to conclude my talk, growth monitoring and anthropometry are invaluable tools in the hands of a pediatrician or a healthcare worker. Please get into a habit of plotting growth until the age of 18 years and not only 5 years. Growth charts will help to reduce expensive investigations as they lead you to a path of what disorder you are looking at, as you just saw. Use WHO charts for children under 5 years, use IIP charts for 5 to 18 years, and many other Indian anthropometric norms, such as West Circumference, are available, and please use them. If there are any questions, I know we are running short of time, but before I end, I would like all the PGs to note down that an effort has been made by many pediatric endocrinologists in India, like Dr. Khadgawat, Dr. Anurag, Dr. Shaila, Dr. Nalini, and I, where we have actually produced a web learning tool for you, which if you complete will give you an American accredited certificate of being trained in growth disorders in children. So if you want, you can just scan this code right away and get onto that website, register, it's free, and train yourself into anthropometry and other things related to short stature. So with that, I would once again like to thank SP, Dr. Jaivinder and Dr. Amarnath, as well as Professor Raghupati and the entire team for giving me this opportunity to try and educate you in growth charts and bone age. Thank you.
So thank you, sir. Thank you very much for a lucid talk. And there's only one question in the chat box, sir. Why the cutoff used for growth velocity is 25th centile? This is the only question.
Right, a good question. The velocity is a dynamic process. So if we wait until the velocity drops to 3rd percentile, like 1 centimeter or 2 centimeter per year, we are going to be too late. We will be too late, and by the time you diagnose an abnormality, it may be beyond repair. So we try to pick it up early. So velocity cutoff is kept at a much higher level. That's the answer.
Okay, thank you. Thank you very much, sir.
Thank you
For your time and your beautiful lecture. And most of postgraduate have learned a lot of things from your talk.
Thank you.
We have maximum participants, sir, with all the sessions. Thank you so much.
Thank you, Dr. Amarnath and Dr. Jaivinder.
So now we will move ahead to the second session for the program. So it would be a case presentation by Dr. Diksha Katur. She is second year PG from Government Medical College, Tanda. Under the case has been prepared under the guidance of Dr. Atul Gupta, who is assistant professor at Tanda Medical College. And the examiner for the today's case would be Dr. Anurag Vajpayee. So Dr. Anurag Vajpayee needs no introduction. All of us have heard the lectures of sir. He is senior pediatric and adolescent endocrinologist at Regency Hospital at Kanpur. Sir has numerous publications and written a number of books, and he has number of videos on YouTube for learning pediatric endocrinology and runs a lot of courses also. So now I request Dr. Diksha to present the case. And Dr. Anurag sir to also examine for this.
Thank you, Dr. Yeah.
Good evening, one and all present here. Myself, Dr. Diksha. I will be presenting case on obesity. I am JR in second year in Department of Pediatrics, Dr. RPGMC Tanda. My guide.
Your slides not visible.
Sorry, sir.
Please share your slide.
Share screen. Share screen, please.
Sir, is my screen visible?
Not yet. Please do it again. Yeah.
Ankit, can you help her out?
Are you getting a share screen button?
Yes.
Yeah, something is
Now
set.
coming. Yeah.
Yeah.
We can see your slides
Yeah.
now.
Can you make it on the yeah, done. Thank you.
I'm presenting case on obesity, and my guide is Dr. Atul Gupta. I'm presenting case of Master C, 15-year-old male adolescent, a resident of Nagrota Bagwa, Kangra, in Himachal Pradesh. Informant is patient and mother, and history seems to be reliable. Patient presented with chief complaint of excessive weight gain for 7 to 8 years, starting at the age of 8 years when he was weighing 25 kgs, and presently he is 15-year-old and is weighing 83 kgs. Patient started having excessive weight gain since age of 8 years in form of tightening of clothes, not able to fit in a standard clothes for that age group. And weight gain was not documented. Weight gain was insidious in onset, gradually progressive. There is history of intake of risperidone at the age of 8 years for 9 months for some psychiatric issue. There is history of rapid weight gain during COVID period. There is history of decreased participation in sports and outdoor activities. And he used to spend most of the time at home in sedentary activities. A screen time of 5 to 6 hours per day for non-academic purposes, and a screen time of 2 to 3 hours before going to sleep. And television was placed inside bedroom. There is history of excessive indulgence in video games, 2 to 3 hours per day. There is history of aggression when denied phone access, and history of bilateral knee pain intermittently, snoring during sleeping. Negative history. There is no history of unsupervised drug intake, no history of constipation, cold intolerance, neck swelling, no history of polyuria, polydipsia, no history of headache, blurring of vision, no history of awakening from sleep, excessive daytime sleepiness, no history of pain, abdomen, vomiting, no history of depressed mood and low self-esteem. Past history. There is a history of intake of risperidone at the age of 8 years for 9 months for psychiatric illness. Birth history, antenatal history. Mother was a bookcase. Total weight gain during pregnancy was 11 kgs. There is no history of gestational diabetes mellitus, gestational hypertension, thyroid disease in mother. Natal history, baby was delivered by full-term normal vaginal delivery. Birth weight was 3 kgs. Baby was exclusively breastfed till age of 6 months, and complementary feeding started at age of 6 months. Baby was breastfed till 3 years of age. There is a history of bottle feeding during infancy. Immunization history. Patient is immunized completely as per national immunization schedule. Developmental history, developmentally appropriate as per age. Studies in 10th plus 1 standard, and is average in scholastic performance. Family history. Patient is only child to non-consanguineous couple. History of marital disputes between parents. Father does not reside with them. History of obesity in mother, and the BMI of mother is 33.2 kg per meter square. There is no history of diabetes mellitus, hypertension, cardiovascular disease in family. Dietary history was calculated using 24-hour recall method. Total calorie requirement was 2,200 kilocalories per day. Total calorie intake was 2,710 kilocalories per day, and there was excess calorie intake of 510 kilocalories per day. There is history of excessive junk food intake in form of oily foods like samosas, momos, potato chips, and frequency was 1 to 2 times per day. And he preferred milk and milk-based products over vegetables and fruits. History of less intake of vegetables, around half katori per day, and consumes fruits occasionally 3 to 4 times per month. Eats while watching television or mobile phone. There is no history of nighttime snacking. socioeconomic status, belongs to upper lower class as per modified Kupu-Swami scale. Anthropometry, weight was 83 kgs and weight for age was between is
Hold on, Dr.
greater
Deeksha.
than.
Yeah, before you go to examination, we'll just maybe have a quick word about the history. So
Yes.
can you summarize the case on history? What are you thinking of in this case? You can hold on here.
Yes, sir.
Yeah. So what is your thought process in terms of history? What are we dealing with?
So since patients started having complaint of excessive weight gain at the age of 8 years, the onset of obesity was after 5 years of age, and there was history of excessive junk food intake, and screen time was greater than 2 hours per day, and their lifestyle was sedentary lifestyle, and there was history of obesity in mother also. So it's mostly so most likely it would be exogenous obesity, and since development of a child is normal, and yes sir.
So what are the pointers which go towards more like a pathological cause in a case of obesity? You mentioned
So
that.
early on, yes.
Yeah, please go ahead.
So onset of obesity, if it is less than 5 years, that is early onset obesity. So if the severity of weight gain is more, and so if there is a history of say any feeding difficulties, or history of hyperphagia, or history of developmental delay, and in child, or history of so abnormal faces. So
Okay.
then these are pointers, and if so there is rapid weight gain.
And did you specifically ask for food foraging or hyperphagia, and how do you really ask for those things on history? Because that is the important part, as you mentioned.
So in case of hyperphagia, there is lack of satiety in patient.
Yeah. So lack of satiety, and they will keep on eating, and they will be searching for food all the time, nighttime awakening. You did mention about those scenarios. What complications do you think this child is suffering based on history? You mentioned a couple of points on history, which may indicate towards the complication that he might be having.
The patient is complaining of bilateral knee pain intermittently. So, it can be because of mechanical excessive weight bearing, or some other causes like slip capital femoral epiphysis, or the blonde disease. And so also my patient is having snoring at night. So it points towards obstructive sleep apnea.
Yeah. So now, before we go towards examination, what are the, so based upon history, you made a presumed diagnosis of exogenous obesity. What are the few key points you will directly like to look at on examination, which will be very important from your further planning perspective?
So first is weight, and then height. So if the height is above than 50th centile, then it points toward exogenous cause. And sir, if height of patient is if there is a short stature, then pathological causes. I would think about pathological causes like endocrine causes.
Okay. Yeah.
Or syndromic.
Yeah. Please go ahead with the examination now, please.
Just 1 second, sir. I wanted to ask one question. Diksha, can you tell me how you take the history of height? You have taken 20 points about the weight. How you take the history of height?
I asked on examination, Dr. Amarnath. What point?
No, sir. I'm asking in history, sir. How will you take? You have not taken much about the height in the history. History.
So on the basis of history, so how would I ask about height of
Yeah.
patient?
Yes, yes. Like
So
weight, yeah.
We can ask if the height is around is around is similar to other children
Very
of
good.
that age group,
Yes, very good.
or
Yeah.
and
When they're standing in the beach, or anything, you should ask. Yeah. Right. So height velocity history also is important for obesity. Thank you.
Yeah. Yeah, carry on with examination, Dr. Diksha now, please.
Anthropometry, weight is 83 kgs, weight for age is greater than 95th centile, that is plus 1.66 Z score, and height is 168 centimeter, and height for age is between 50th and 75th centile, and is and lies at minus 0.58 Z score. BMI is 29.4 kg per meter square, and BMI for age is greater than 98th centile, that is plus 2.16 Z score, and interpretation is obese. Waist circumference is
just
99 centimeter and is greater than.
Yeah. Just hold on, Dr. Diksha. So this BMI for age, which cutoffs are we using here?
Ma'am, OPG.
So we are using the IAP cutoffs. So for boys weighing boys at 5 to 18 years of age.
How do you define the obesity in IAP?
In IAP, so we use BMI. If the BMI is greater than 27th adult equivalent, then we interpret it as obese.
Yeah, so I think that is pretty much what we would have looked at. Anyway, the BMI in absolute figure is already high. So, so the main message is that we don't really look into the percentile scores. There are specific Z scores which give you the cutoff, but we're looking at the backtracking from the adult cutoff. I think that's the main message I like to give from that regard. Carry on.
The background, Rishabh, please. Ankit. Yeah, sorry.
Carry on, Dr. Diksha. Yeah.
Waist circumference is 99 centimeter and is it is greater than 98th centile, and waist hip ratio is 0.96.
So based upon this growth chart, what is your pattern and thought, whether it is a nutritional versus a pathological obesity?
So since so height is lies between 50 and 75th centile, then so most likely this is so nutritional obesity.
Okay, yeah. Carry on.
General physical examination. Patient was oriented to time, place, and person, cooperative and interactive. Vitals were stable. BP, both systolic and diastolic BP lies between 50th and 90th centile. There was no paraicterus, clubbing, cyanosis, lymphadenopathy, and edema. No obvious dysmorphism. Acanthosis nigricans grade 3 seen over nape of neck and axilla. Hump over back of neck present. SMR stage 3. Gynecomastia grade 1 present. There was no tonsillar hypertrophy.
Yeah.
My patient lies at a grade 3, that is acanthosis nigricans in neck extending to the lateral margin of neck but not visible from front, and in axilla moderate involving entire axillary fossa but not visible when the arm is against the participant's side. Systemic examination was within normal limits. Database: 15-year-old male adolescent with complaints of excessive weight gain for 7 to 8 years, intermittent pain in bilateral knee and snoring during sleep, with a history of excessive junk food intake, lack of physical activity, screen time of 5 to 6 hours, history of risperidone intake for psychiatric illness at age of 8 years, with history of obesity in mother, with broken family, and belongs to upper lower class. On examination was obese with waist circumference of greater than 90th centile and acanthosis nigricans present, normal stature, no dysmorphism, no developmental delay or intellectual delay. Provisional diagnosis: obesity, that is exogenous obesity, and associated comorbidities, obstructive sleep apnea, insulin resistance, gynecomastia, to rule out metabolic syndrome.
You have mentioned a lot about, so you have mentioned about the risperidone use. What is the implication of risperidone, and what is the effect on risperidone on the metabolic process?
So risperidone is antipsychotic medication, and so it causes modest weight gain.
And greater amount of insulin resistance. So we have seen many patients with even slightly high BMI in which it may trigger development of metabolic syndrome and type 2 diabetes. So I think that's an important point you brought out. So clearly what you have mentioned is that this looks like an exogenous obesity and so many lifestyle factors. What will be your assessment plan in terms of investigations from here?
Firstly, so we would like to do LFTs and RFTs. So I would like to check a lipid profile. So for insulin resistance, I would like to check fasting blood sugar and then so OGTT, and if fasting blood glucose is abnormal, and other examples. So since my patient is having knee pain, I would like to check X-ray of bilateral knee and bilateral hip, and so for ENT examination to look for any tonsillar hypertrophy, and so USG abdomen to rule out to rule out NAFLD.
Okay, very good. Would you be doing any endocrine workup at the moment, like thyroid profile?
Yes, sir.
Okay, so even if, so this is an important message. I think you already said that this doesn't look like an endocrine cause, but since hypothyroidism, often we see a lot of variations, it may be prudent to do a thyroid profile. So can you go ahead with the examination results that we found in this case?
Yes, so on examination, patient was on investigation.
Yes, investigation results. Yeah.
Yes, sir. The SGOT and SGPT 27 and 30 international unit per liter respectively, urea and creat 16 and 0.8 mg per deciliter respectively. Lipid profile, cholesterol 119 mg per deciliter, triglyceride 139 mg per deciliter, and so high for this specific age group. HLD 42 mg per deciliter, LDL 50 mg per deciliter, VLDL 28 mg per deciliter, and fasting blood sugar of 87 mg per deciliter, serum insulin fasting 7.9 milliunits per liter, T3 131 nanogram per ml per deciliter, T4 7.7 microgram per deciliter, TSH 3.57 micro international unit per ml, fundus examination normal, LH 1.75 milli international unit per ml, FSH 2.4 milli international unit per ml, serum cortisol 6.2 microgram per deciliter. USG abdomen suggestive of grade 1 fatty liver disease, bone age equals to chronological age, that is 15 years as per GR Atlas, X-ray bilateral knee normal. Psychiatric consultation was sought for anger outburst issue and whenever asked to leave mobile, diagnosed as F34.2, that is persistent mood disorder, and was started on fluoxetine, and behavioral therapy and counseling session for anger management started. Final diagnosis, exogenous obesity with persistent mood disorder with associated comorbidities, obstructive sleep apnea, dyslipidemia, and gynecomastia, and NAFLD, a non-alcoholic fatty liver disease.
Okay, so you have seen a lot of complications in this case. How would you suggest in terms of further management beyond lifestyle? Would you think of any medications at the moment?
Firstly, we would like to start lifestyle modification for 6 months. If these modifications fail, then I would like to start this patient on therapy, pharmacological therapy, and only Orlistat is FDA approved. So we can start. Then we can later use Orlistat.
I think that's a very good workup in terms of exogenous cause. And key thing just to mention is that many of the parameters that you mentioned in terms of mild elevations of TG and this non-alcoholic fatty liver on ultrasound, these are very, very common. So we should not rush towards medicating patients for that. Unless and until your ALT levels are very high, unless and until your TG levels are very high, they are the only ones which require treatment from that regard. So I think this was a very good case in terms of how to approach a case of exogenous obesity, how not to do unnecessary workup. Just a few points as to why did you do the LH, FSH and cortisol?
Since patient was having gynecomastia, that's why. But so in obesity, mostly it is pseudo gynecomastia because of deposition of adipose tissue.
And the pubertal status you mentioned was?
Stage SMR stage 3.
So yeah, so probably we could have avoided those investigations, but yes, complication screenings were very well done in this case scenario, I think. Yeah. Maybe you can carry forward from here.
Yes, sir. Some managements include lifestyle modification, which include a decrease in non-academic screen time to
Can we
less than.
move to the
We'll move to the
next
second
case?
case, I think. That will be a quicker one. Yeah, please move to the
Yes,
second.
yes.
Yes, sir. Second case I'm presenting is Master R, 3-year-old male child, resident of Rajora, Kangra, presented with complaint of excessive weight gain from age of 6 months to 3 years, and history and complaint of increased appetite from age of 6 months to 3 years. History of present illness, presented with history of excessive weight gain since age of 6 months, which was insidious in onset and gradually progressive, with weight gain of 1 to 1.5 kg per month approximately, with history of voracious appetite, and was exclusively breastfed for 6 months. And was breastfed every hourly, and complementary feeding started at 6 months, predominantly cow milk, used to drink 5 to 6 liters per day. Used to get upset and aggressive if denied food, history of snoring at night intermittently and mouth breathing. Their history of screen time of 2 to 3 hours, prefers milk and milk-based product over vegetable and fruit. There is history of less intake of vegetables and consumes fruits occasionally. There is no history of poor height gain, no history of recurrent infection, no history of feeding difficulties in infancy, no history of looseness of limbs and or body, no history of constipation, cold intolerance, neck swelling or hoarseness of voice, no history of night awakening, excessive daytime sleepiness, no history of headache, no history of abdominal pain or vomiting. Antenatal history, mother was a booked case, and there was no history of gestational diabetes mellitus, gestational hypertension or thyroid disorder in mother. Weight gain during pregnancy was 10 kgs approximately. Birth history is full term normal vaginal delivery. Birth weight is 3.2 kgs, and baby was immunized as per national immunization schedule. Developmental history, developmentally appropriate as per age. Dietary history, total intake of total 2000 kilocalories per day, and 1010 kilocalories per day. Excess intake of 1190 kilocalories per day. Family history, was first born to a non-consanguineous marriage couple. There is history of 2 abortion in mother, and the younger sister is also obese with weight of 22 kgs at 2 years of age, and the history of 3rd degree relative with morbid obesity with onset in childhood, who expired at age of 25 years. Father expired 6 months back, diagnosed as a head and neck carcinoma, and history of no history of diabetes, thyroid disorder in family member. Socioeconomic history, belongs to lower class as per modified Kuppuswamy scale.
So I think before you go for examination, what are the pointers in this case which make it more likely to be different from your first case? You can stay there only. Yeah. So what are the pointers which are telling you that this is not likely to be a simple exogenous obesity?
Since such onset of obesity is at around 6 months, and so it is early onset obesity. So this goes towards pathological obesity, and there is history of excessive weight gain. So from history itself, we can make out that weight gain is severe. So, sir, it also points toward pathological cause, and sir, also there is history of hyperphagia, voracious appetite, and lack of satiety. So these, and history of positive family history also. So these all are pointers toward
so this basically fits into the classical criteria. There are 4 criteria for any genetic cause: too soon, segregating, syndromic, and severe. So all 4 are there in this case. So I think this is a very, very clear case of genetic etiology. And what sort of inheritance do you think we're looking at in this case?
Autosomal recessive type of inheritance.
Because 2 siblings are there, and there are the other family members which are affected separately. Yeah. So I think you can carry forward on examination quickly.
Yes, sir. The general physical examination, patient was oriented to time, place, and person, and cooperative and interactive. Vitals were stable. The blood pressure in right upper limb and lower limb was between 90th and 95th centile. So which was elevated blood pressure, and SpO2 98% in room air, and while sleeping 97 to 98%. Generalized obesity present, appears tall for his age. There is no history of icterus clubbing, cyanosis, lymphadenopathy, and edema. No obvious dysmorphism. Severe acanthosis nigricans, grade 4, seen over the nape of neck and axilla. Genitalia normal, a male phenotype. Bilateral testes descended into scrotum. Bilateral grade 3 tonsillar hypertrophy present. The child in black t-shirt is my patient, and other one is his sibling.
Yeah.
Anthropometry, weight is 37.6 kgs, that is plus 9.05 Z score. Height is 108 centimeter, that is plus 2.4 Z score. BMI is 32.24, that is plus 10.64 Z score. Weight for height is plus 9.76 Z score. And head circumference is 54.3 centimeter, that is plus 3.17 Z score. Upper segment and lower segment ratio is 1.34:1. Mid-parental height is 166.
So Dr. Diksha, given the severity of obesity, what would be your
Yes, sir.
most likely consideration and the most important workup you'll think of from here?
We would like to do routine investigations like RFT, LFT, lipid profile. So we would like to check for insulin resistance. We would like to do fasting blood sugar, OGTT, and USG abdomen. So since there is ENT evaluation or polysomnography if available in our institute, and so we would like to look for genetic causes, so since there is strong family history.
So I think this is very important. So this case is totally different from the earlier case. This really says that this is pathological written all over. We have to consider the genetic etiology significantly in this case. So you can quickly go to the investigation that you ordered.
Yes, sir. Urea and creat 14 and 0.3 mg per deciliter, bilirubin total 0.4 and direct 0.04 mg per deciliter, AST, ALT 111 and 131 mg per deciliter, which were elevated for that age group, and T3 1.72 nanogram per ml, and T4 5.8 microgram per deciliter, TSH 2.17 milli international unit per ml, cortisol 190 mole per liter, ACTH 28.4 picogram per ml, fundus within normal limits, bone age 3 years, that is equivalent to chronological age, 54.8 and C-peptide 4.49 nanogram per ml, HOMAR IR 10.48, suggestive of significant insulin resistance, OGTT fasting sugar levels 111 that are elevated for that age group, 1 are postprandial 132, 2 are postprandial 106, lipid profile total cholesterol 171 mg per deciliter, LDL 117.2 mg per deciliter, HDL 25.8 mg per deciliter, triglyceride 271 mg per deciliter.
So if we compare this case to the previous case, clearly we have got much worse findings in terms of the liver profile, in terms of the OGTT, as well as the lipid profile. So this is much early and much more severe from that perspective. Now, would you recommend insulin assessment in everybody with obesity?
No, sir. OGTT, we should check OGTT levels, and so insulin, checking for insulin is not recommended in all cases.
It may be done as part of a research or academic. So the message is for all the postgraduates is that we don't need to routinely do insulin profile, C-peptide and HOMA unless it's part of any research project, because we are measuring the peripheral insulin, which is not going to really help out. We want to assess the portal insulin resistance. So OGTT, as you showed, clearly showed a impaired fasting glucose, which was very significant. Yeah, now carry on.
ENT evaluation revealed bilateral grade 3 tonsillar hypertrophy. USG abdomen revealed hepatomegaly with grade 2 fatty infiltration. X-ray soft tissue neck was within normal limits, and leptin level were 29.02 nanogram per ml and were elevated. Genetic testing revealed defect in leptin receptor, and location was intron 3 and variant was 53 splice site, and zygosity was homozygous, and associated with morbid obesity due to leptin receptor deficiency, and inheritance is autosomal recessive, and classified as pathological. Final diagnosis: severe early onset obesity, monogenic obesity secondary to the leptin receptor gene mutation with metabolic syndrome and associated comorbid conditions, obstructive sleep apnea, elevated blood pressure, insulin resistance, and a dyslipidemia, and a non-alcoholic fatty liver disease.
I think the big message from this case clearly is that if you have a very, very early onset with a very severe obesity with hyperphagia, think of a genetic cause, and the availability of the targeted panels and the next generation sequencing will help you out. Biochemical parameters are a bit variable. So here you found leptin to be slightly high, but leptin levels are high in obesity. So we have to correct them for BMI. So all those implications become important. What are the other possible endocrine causes which you can rule out quickly at this age, which can have a very high level of obesity as well?
It can be because of the syndromic causes. So there, in case of syndromic causes, there would be a history of the developmental delay. There would be
talking about the syndromic ones. Of course, you will get the dysmorphism and faces. Are there any particular endocrine conditions like which can cause such early onset of obesity, which you can identify?
So Rohard can cause early onset obesity, rapid early onset obesity.
And pseudo hypoparathyroidism. So that's why TSH becomes important. Your TSH may be slightly high, your PTH may be slightly high, which will give you a PTH resistance, and PHP can cause that picture as well. Rarely we have seen diabetes insipidus presenting with severe obesity when they're drinking a lot of feed, but that's a bit earlier onset from that. But this is a classical case of the monogenic obesity, so to speak. Any other inputs, Dr. Amarnath, you like to add here? Or Dr. Atul?
Sir, MC4R gene mutation, they can cause picture.
And generally, this child is less towards leptin, it's more towards the MC4, it's more tall and no immunodeficiency. But yes, we do see all the variations which may be there from that regards. Yeah. So I think the cases were very well worked up and presented two very classical contrasting cases. The one in which it was clear that the height was normal, it was later onset, clearly exogenous obesity. The second, very early onset, significant complications, more like a monogenic obesity. So thanks, Dr. Diksha, for the nice presentation. And I think we can carry forward from here.
Yes.
Just one answer, sir.
Yeah.
So I request all pediatricians and postgraduates, please kindly start recording high. Whenever any patient is coming, both inpatient and outpatient, it helps a lot to you and also to the pediatric endocrinologist. That's how weight velocity is very important. Please do that. That's the one take home message from myself. Thank you, sir.
Thank you. Thank you.
Thank you, Dr. Diksha and Dr. Atul, for nice cases, and we have very good take-home messages from these cases, and we have a good exercise with how the cases should be presented in exam and what sort of questions can be asked. Now I invite Anurag sir to present his lecture on endocrine diagnostics.
Just 1 second, sir. I request Dr. Atul, sir, to just present the approach to obesity 1 or 2 slides. Sorry for the interruption, sir. Just approach to obesity, just 1 or 2 slides. Atul, sir, are you ready?
Diksha, can you stop sharing?
Yeah.
From my screen?
Can you help out?
Is the screen visible, sir? Actually, message is coming, cannot start screen sharing while the other participant is sharing. So, Diksha, you will
ma'am, you have to
stop
sharing your screen, ma'am. Dr. Diksha, ma'am.
Or is it in the same slides? Atul, sir, can you please? Yeah.
we eat it flows into the bathtub, and whenever we do physical exertions, the basal metabolism is the way in which we are able to get away with the energy. So this is the only way out for how we can explain to PGs that how energy is being used or utilized in the body.
Dr. Atul, your slides are not visible and your voice is very low.
Sir, are they visible now, sir? Actually,
Not yet visible. I think we can take it. So please continue, sir. Sorry for the interruption. We request Anurag sir, please continue. Afterwards, we'll see. Yeah.
Okay, so shall I start the presentation, Amanat?
Please go ahead, sir. Thank you, sir.
Okay, thank you. We can have Dr. Atul's presentation maybe after that, by the time it's sorted out. So at the very offset, I like to thank the organizers and the wonderful team ISPAE and ISPAE PEP for this invitation. Real congratulations and thanks to Dr. Raghupati and Dr. Amarnath, who have been tirelessly working in this regards, Dr. Ahila and Dr. Jay, Javinder, who have been working in this regard. So I've been given the task of covering endocrine diagnostics in a period of 40 minutes. So it's a very extensive task. I am covering 4 topics. So the key issues which we'll be focusing today are growth hormone evaluation, pubertal assessment, DSD, and adrenal disorder. So it's a cumbersome task. I'll try to see how much we can cover and how do we go forward on that. But this will be a practical one in terms of evaluation and assessment. So before we start, all of you can go and have a look at our website, learning.growsociety.in, where there are a lot of videos and modules available for assessment and evaluation of pediatric endocrine disorders. So when we talk about growth failure evaluation, the first key message is when you go for growth hormone evaluation, it should be the last thing. It should not be the first thing to do. So when we talk about growth failure, 80% of cases are physiological, and they are most commonly because of constitutional delay of puberty and growth and familial causes. And only a small fraction will have a pathological causes. So you have to first exclude the other causes, and the most important thing to exclude the constitutional delay of puberty and growth and familial is to look at a careful assessment of growth chart and bone age, as Dr. Vaman had mentioned, and a look at puberty. So if you have a child who is short for the population, short for the family, and short for the bone age, then you think it's pathological and you move towards the next arm in terms of evaluation. Initial focus would be to look at the primary causes, losing the facies and body proportion, look at birth weight. Then in girls, look for karyotype, because Turner's is a very, very common scenario. Go for genetics. We are seeing more genetic causes now, as well as the skeletal disorders, which may cause these disorders. Now, after you excluded the primary causes, go for a nutritional causes in the form of liver disease, kidney disease, celiac disease, very importantly, also along with IgA, and a blood GAN analysis in children who are less than 3 years of age, and calprotectin after 10 years of age. Only after all this workup has been done shall we go ahead with a growth hormone stimulation, especially when your thyroid profile is normal. So my talk starts basically from this end. You're already evaluated for all these causes, and we're now looking for growth hormone assessment. To make it more simple, think of growth hormone deficiency only if the child is very short, height is below -3 standard deviation score, or growth is between -2 to -3, and the growth velocity standard deviation score is much less. If there are other features, of course, you become more clearer. If there are features of micropenis, generalized obesity, doll-like facies, neonatal hypoglycemia, cholestasis, and undescended testis, you are more likely that this could be a multiple pituitary hormone deficiency or a growth hormone deficiency, and you will need to evaluate in a more comprehensive manner. Now, why we need to be selective in terms of evaluation of growth hormone is that, because like any other test, growth hormone tests are also associated with variable diagnostic values. So they may have false positive and false negative. So if your pretest probability is low, having a positive growth hormone test will not have the same meaning as if your pretest probability is high. And that's why we want to choose patients correctly before you do the evaluation. Very importantly, if you already have a clear-cut scenario where you need to give growth hormone, like a SGA with a poor catch-up, like Turner syndrome or skeletal dysplasia where growth hormone therapy is not beneficial, there is no rule of doing a growth hormone stimulation test unnecessarily, because that's not required from a therapeutic perspective. Now, what are the common challenges in terms of assessment? So we all know that the axis, the GHRH, is the main regulator of growth hormone secretion from the pituitary, which then acts on the growth hormone receptor in the liver to produce IGF-1 and BP3. So we can look at either growth hormone directly, or we can look at IGF-1 and BP3, which are the dependent peptides on that. And IGF-1 is the final mediator as far as growth is concerned. Now, the big problem with growth hormone is, and where a lot of pediatricians and postgraduates stumble, is that they do a basal growth hormone. Now, growth hormone is a pulsatile hormone. You've got very small time in which growth hormone levels are really high. So if you measure a growth hormone at a basal level, your levels will be low. So basal growth hormone is a waste of money. Every OPD, we see so many patients who come to us with a low basal growth hormone, asking for growth hormone treatment. It is of no role at all. So clearly, if you want to really assess the growth hormone excess, we have to give a stimulating agents like glucagon, insulin, or clonidine, and that will really increase the level of growth hormone. And then we can go ahead with a higher cutoff to identify. So therefore, as the basic dogma in pediatric endocrinology goes, if you are deficient, do a stimulation test. If you're talking about excess, do a suppression test. And therefore, there is no role of basal growth hormone. We should definitely go ahead and do evaluation in terms of a growth hormone stimulation test in that regards. Now, we have got our option of doing the assessment for IGF-1 or BP3 using a screening strategy, or we can measure growth hormone stimulation, which is basically the confirmatory test. And that's what is very important to understand. Now, when we compare IGF-1 and IGF-BP3, which are growth hormone dependent peptides, important to remember that IGF-1 depends on the age, the nutritional status, and the liver function. So it's unreliable before 3 years of age in somebody who has got malnutrition and somebody who has got a liver disorder. In these scenarios, BP3 may be a better strategy to look at. Now, these are screening tests, so they have got high sensitivity, but their specificity, especially for IGF-1, may not be good enough. And if you have a low level of IGF-1 and BP3, you have to do a growth hormone stimulation to confirm that. So their major role essentially is to exclude growth hormone deficiency. If the level is normal, you can say, okay, growth hormone deficiency is very, very unlikely. But these tests are very expensive. They are not easily available norms as far as Indian setting is concerned. So their role has to be done with caution in that perspective. However, in certain scenarios where your pretest probability of growth hormone deficiency is very high, like malformations, CNS insults, tumor, or radiation, where you know, okay, growth hormone deficiency is very likely, in that scenario, these tests, if they are low, can be diagnostic, and you don't need to do a growth hormone stimulation test from that perspective. But whenever you plan a growth hormone stimulation test, it has to be very, very meticulously done. You need to have a normal level of thyroid and cortisol because they will affect the growth hormone level. It should ideally be done in a fasting morning sample, and only if you have a clear-cut oxological indications which are there. There are various tests which are available. The gold standard has long time been insulin tolerance test, but it has a high risk of hypoglycemia. So it has to be done with extreme caution under very, very careful monitoring. The other test, which is most commonly done on the outpatient basis, is the clonidine stimulation test, which is pretty safe. You just have to monitor blood pressure, and the glucagon test, where again, you have to monitor blood sugar because there is a rebound hypoglycemia, which may happen. Now, if we compare these tests, there may be some variability in terms of responsiveness and the levels, but overall, most recommendations consider them to a similar in terms of response. So we have got a common cutoff for these tests. We now have the growth hormone secretagogue-based test, mesomorelin test, which is going to be available soon. It's been proven to be quite effective in adult GHD and may be the way forward in children as well. Now, the cutoffs have been an area of debate. Normally, people have been talking, if you want about complete growth hormone deficiency, the level is less than 3. But since then, the cutoffs were varying from 5 to 7 to 10. The latest GRS criteria talk about a cutoff of 7 nanogram per ml as a criteria for growth hormone deficiency. Now, once you find one test to be low, ideally you should do 2 tests. But if your pretest probability is very high, even a single positive test will be quite significant. Neuroimaging, of course, has to be done to exclude the possibility of a CNS pathology. In conditions where there may be an evolution of growth hormone deficiency on follow-up, you need to do a repeat test, especially in the settings of radiotherapy, somebody who has got neurosurgery, somebody who has got underlying malformations which may produce and progress subsequently. Very importantly, you may also be asked to evaluate for a neonatal growth hormone deficiency where random growth hormone or particularly low growth hormone during hypoglycemia may be considered to be sufficient as a criteria. And in adults, insulin tolerance test is considered to be diagnostic. Clonidine is not very specific and the cutoffs are lower. So you have to be very careful about what cutoffs, what setup you have to evaluate and manage from that perspective. And there are many things which can cause confusion. Prime of them is the lack of estrogen. Now we know that both for boys and girls, estrogen is what regulates the growth hormone secretion. So if somebody is in a delayed puberty state, their levels of growth hormone may be falsely low and you will falsely label a CDGP child, a constitutional delay of puberty and growth child, as growth hormone deficient. So what is recommended that is that if you have a girl who is 10 years and above, and boy who is 11 years and above and who hasn't entered puberty, you should consider a sex hormone priming. You give them estrogen or testosterone so as to increase growth hormone levels, especially if you're thinking of CDGP as a possibility in that the predicted adult height is in the target height range. The agents you can use is estradiol in both genders, or you can use testosterone in boys and estrogen in girls. But this is something very importantly, this will avoid a false positive diagnosis of growth hormone deficiency. Another condition which may falsely cause a diagnosis of growth hormone deficiency is obesity, because obesity increases the inhibitory tone, causing decrease in growth hormone, which is actually a growth hormone sensitive state. So there are some consideration whether you need to use lower cutoffs in obesity, and these things you have to consider from that perspective. So just to summarize about the entire evaluation of the growth hormone IGF-1 axis, if your levels are low for both growth hormone IGF-1 and IGF-BP3, you're dealing with growth hormone deficiency. If you have the rare scenario in which your growth hormone is high, IGF-1 and BP3 is low, it's most commonly a growth hormone receptor problem. If you have got a high level of GH and IGF-BP3 while IGF-1 is low, this is a primary IGF-1 defect. And if all are high, you're dealing with the IGF-1 receptor defect. So if you interpret it appropriately, these will be rarer conditions. You just need to be aware that this may happen. In scenarios where you want to really assess growth hormone sensitivity, we give growth hormone for a few days and assess IGF-1 level and see whether it's responding or not to identify growth hormone insensitivity. So the key message as far as growth hormone evaluation is concerned is that do it only in a stimulated one, think of priming and exclude other causes before you do the evaluation. So we have got this child who is 12-year-old girl, and we can clearly see the child is very short. She had a normal TTG and TSH, and somebody diagnosed growth hormone deficiency based upon a low level of IGF-1 and a low basal level of growth hormone. Now, if you look at the chart, we clearly see that this child has got a predominant effect on the weight. So this is more likely to be a nutritional cause rather than an endocrine cause. So this is not clearly looking into growth hormone deficiency. IGF-1 may be falsely low in nutrition abnormalities, and basal growth hormone is not much role. So we should do a stimulation test, which will give you the diagnosis. Another big dilemma is this typical case, a 13-year-old boy who is just below the growth chart, but his bone age is also delayed. He is prepubertal. Now, this child was evaluated and was found to have a slightly low level of growth hormone labeled as GHD. 99.9% of boys in this sort of a growth chart would not be GHD. They will be constitutional delay of puberty and growth. So what went wrong in this case that there was a non-primed growth hormone stimulation. We should have given testosterone before doing the test, and when we repeated, the growth hormone was a good response and the child continued to grow. So very importantly, in somebody who is peri-puberty, who hasn't entered puberty, there is a slight growth failure. Do a priming before you really go ahead in terms of evaluation, because otherwise you will be misdiagnosing from that perspective. So this is something which is important to identify. So now we have covered the key aspect about growth hormone evaluation. The next step will be about puberty. And puberty, the most important, of course, is to look at clinical diagnosis and assessment of puberty. And this is something which we often tend to miss because we think it's more complicated, difficult to do. So in terms of pubertal assessment in girls, the key is to look at two breast stages. So breast stage 2, which is the papilla elevation. And often with obesity, we are getting a lot of lipomastia. So what we advise is that you approximate your thumb and finger along the areolar region. And if there is resistance, it means there is a true breast tissue. Why B2 is important? Because this is the onset of growth spurt. From here, you expect around 20 centimeters of growth, and you can add 20 centimeters to the current height to get a final predicted height. Stage 3 is the development of primary mound, which may be confusing, but what's very important is stage 4, which is the development of secondary mound. And this is the time where you are very, very close to the menstrual cycle, and the growth is limited to around 5 to 8 centimeters. The typical gap between the breast development and stage 2 and stage 4 is around 2.5 years, and you have got another 10 centimeters from here. The development of vaginal discharge clearly is a marker that the menarche is going to be very, very close on that regards. Importantly, this is a typical pattern of pubertal development, but the tempo of puberty may vary. It may be very rapid in SGA, so they can develop puberty very quickly. In obesity, you may see the opposite. You will have earlier onset of puberty, which will be very slowly progressive from that regards. And if you have an earlier onset of puberty, usually the duration of puberty is more. So evaluation of puberty, breast examination is very, very important. The second aspect also is the pubarche, which gives us the information about the adrenal axis. Now, generally, the adrenal axis awakes around 6 months later than the ovaries, but really you can have an earlier onset. Again, we are seeing a lot of stage 2 pubic hair, which may or may not be significant. So these are usually longer than vellus hair. They are short, straight, and light. You can say you can compare them with forearms, so they will look like the forearm hairs. To me, what's very significant is stage 3, which is the medial growth, longer, thicker, curly, and pigmented. So if you've got stage 3 pubic hair, this means definitely this girl has entered into significant pubarche. And then, of course, from there, stage 4 and stage 5 become significant. The assessment of breast and pubic hair development has got real clues in terms of the likely diagnosis for precocious puberty and delayed puberty, and that's why you have to be very cautious in evaluating them. And sometimes you may have an earlier pubarche without thelarche, which may happen. There could be a discrepancy, and axillary hair typically happen after 1 year. So when you want to look at the pubertal status in girls, you can look at estradiol levels if they are more than 10. But remember, the estradiol assays are meant more for adult women in the reproductive age group. So at lower levels, these assays are not very good. So you may have a falsely low estradiol level, which may not give you the good diagnosis. So if you want to really look at the estrogen status, look at the breast and look at the vaginal mucosa. You spread the legs, look at the vaginal mucosa. If it's pale, it suggests estrogen exposure. If it's red and glistening, it means it's prepubertal. And this is vital. It may save you unnecessary workup. If you don't find any estrogen exposure, you do not need to do any workup for precocious puberty. Of course, uterus, increase in endometrial thickness and change in the shape of uterus from a tubular structure to a globular structure will suggest that you are now entering into puberty. And of course, discharge abdominal pain may be a late manifestation of pubertal status in girls. Very importantly, gonadotrophins have a very typical pattern in which they progress. So we see that FSH is already higher compared to LH, and the rise in FSH during puberty is only 1 to 2 times. But the LH rises by around 10 times. So clearly, LH is the best indicator for the onset of puberty, and that's something which is absolutely important. And when you are looking at, you can either look at the basal level or you can do a GnRH stimulation test using uprolide or triptorelin, in which you assess the LH levels after 2 to 4 hours. And if your LH levels are high baseline, you don't need to do a GnRH test, especially in most young girls. More than 0.2 is significant. And then if agonist stimulated is above 5, it's definitely suggestive of onset of puberty. In girls who are very young, because of the mini puberty, your levels may be high, so higher cutoffs are recommended. So look for LH, and if required, do a GnRH stimulation test from that regards. What about boys? The most important thing to look at is the testicular volume. So the testicular volume above 4 ml indicates that you have onset of puberty, and you can assess them using orchidometer. A testicular volume of 10 ml will suggest that you are really now into the growth spurt, and you've got rapid growth happening very soon from that regards. Now, if you really correlate the testicular volume to testosterone levels, you can get good ideas. So generally, 20 nanogram per DL is equivalent to 4 ml. So if somebody's early morning testosterone level is 20, the boy has entered into puberty from that regards. And then subsequently, you have got further development and you get adult status typically above 15 ml of testicular volume. So testicular volume is a good surrogate for the actual production capacity or the Leydig cell capacity of the testis on that regards. But what is important to remember is that often you may be asked to evaluate for testicular functions in the prepubertal age group, where testosterone levels will be low. Remember, if you see the graph, the testosterone levels are high in the initial phase. There's the mini puberty. They go down by 1 to 2 years and then rise around 12 years. So what do you assess in somebody who has, let's say, cryptorchidism, somebody you want to assess testicular function? The best marker there, of course, is the AMH, which is high throughout childhood. If you want to look at the onset of puberty, inhibin B will be a much better marker, and we'll use that in one of our algorithms, which I'll show you, which will be a better marker in terms of identifying the onset of puberty subsequently. And of course, in scenario where you want to know more, you can do a CG stimulation test. But now AMH and inhibin B are the best markers. They are produced by the Sertoli cells about testicular function in terms of assessment and diagnosis from that regards. So now this is a very important slide to look at. When would you consider something to be abnormal? So normal breast development happens around 10 to 11.5 years of age. Onset of thelarchy before 8 years or no thelarchy beyond 13 years is suggestive of precocious and delayed puberty in girls. Pubarchy, largely we're dealing with precocious, so onset before 8 years of age. Menarche before 9.5 years of age becomes significant, and delayed puberty if you have no menarche by 15 years of age. Similarly, if the testicular enlargement happens before 9 years in boys or does not happen by 14 years, you're thinking of precocious or delayed. So you should remember this slide very importantly. This will tell you, and this will save a lot of unnecessary workup in many cases, which we often see in pediatric practice. So now I'll just quickly go through the 4 conditions as to how do we use these investigations to reach a diagnosis. So if you have a girl with precocious puberty, onset of breast before 8 years, menarche before 9.5 years, look at the presenting features. If you have only pubarchy, get a DHEAS done, which is a marker of adrenal androgen production. DHEAS is low. This is idiopathic, nothing to worry. If it's 40 to 135, this is marginal. Wait and watch. But if the DHEAS levels are high, you have to think of a pathological cause. Look for adrenals and look for CAH as a possibility. If you have a girl who presents to you with no breast, only periods, think of a local cause. This is not endocrine. Think of a trauma, tumor, abuse, foreign body, gynecological referral becomes important. If you have somebody who has got complete development of thelarchy and the bone age is retarded, you have got a clear-cut diagnosis of hypothyroidism. Short girl with precocious puberty, delayed bone age, hypothyroidism. Look at thyroid profile. If your bone age is advanced and the LH levels are prepubertal, it's rare. It's basically a peripheral cause. But if it's pubertal, think of a central cause and consider MRI. So key is to look at what extent puberty has happened and how do you reach a diagnosis from that perspective. In boys, the most important investigation is LH. If LH is high, this is central. You need to do evaluation, do an MRI in that perspective. LH is low. Most importantly, think of CAH and an adrenal mass. So if you have an adrenal mass or your 17-OHP is high, the pathologies are there. If both are not there, there are rare possibilities of a HCG producing tumor or testotoxicosis. So the key message is LH again becomes very important. And if you have central precocious puberty in boys, always think of pathology. Precocious puberty is rare in boys, but if it's there, it's more likely to be pathological. And that becomes extremely important. What about the intermediate? You can do a GNR stimulation to get the right diagnosis. Coming on to delayed puberty, which is lack of breast development by 13 years of age. In this scenario, the first is to exclude a systemic illness. So you look at liver function, kidney functions, thyroid, celiac, prolactin. If all are normal, go for gonadotropin levels. If you have got a high gonadotropin levels, think of Turner's as the first possibility, which is very, very important. If your gonadotropin levels are low, you have to look at CDGP or constitutional delay as a possibility. So look for pathological causes. If there are neurological features or anosmia, then you think of a possibility of hypogonadotropic hypogonadism. Otherwise, it's more likely to be CDGP from that perspective. So the key message is in delayed puberty, rule out systemic illnesses, do a FSH, low FSH, you do a GnRH testing and then classify and go from that perspective, and that becomes important. Delayed puberty in boys most commonly is because of constitutional delay, 70 to 80%. So of course, you start off with screening investigations. If the gonadotropin is high, you're dealing with a testicular failure. In this scenario, you do karyotype and further workup will give you the classical picture. This scenario in boys most commonly will be Klinefelter syndrome in that regard. However, if your gonadotropin levels are low, you are in a dilemma whether this is a constitutional delay of puberty and growth or you're dealing with a hypogonadotropic hypogonadism. So in that you go for clinical features. If they are anosmia, if there is undescended testis, if there is micropenis, you're thinking more likely a permanent cause. If they are not there and the testicular volume is very small, inhibin B comes to your rescue. If your inhibin levels are very low, it's permanent HH. While if your testicular volume is high, above 1 ml, and inhibin B is high, you are dealing with CDGP. In the interim scenarios, you can do a GnRH test to make a diagnosis of either permanent HH or CDGP. So just using the principle, exclude the systemic causes, look at the FSH levels, high FSH, hypergonadotropic, go for karyotype, low FSH, low LH, think of testicular volume, neurological features, features of Kalaman syndrome and inhibin B. You will distinguish between CDGP and permanent HH. CDGP is important because there you only need to give a push of testosterone and you will have onset of puberty, while permanent HH will have long-term implications in terms of lifelong treatment as well as fertility implications which are there. So pubertal assessment becomes extremely important and careful assessment will give you the diagnosis. We have developed a mobile application which is being validated, which really gives very simple tools to assess in terms of on basic inputs will give you the diagnosis of different pubertal disorders and assessment from that perspective. We'll now quickly move towards a very complicated topic of BSD and see what sort of investigations we need to do. So when we talk about disorder of sexual development, we are talking about either a XX DSD, which means that an individual who's going to become a girl has got a lot of androgens exposure. In this scenario, you have got uterus will be present while there will be no gonads. Now, this scenario would be because of androgen excess, which is most commonly 21 hydroxylase deficiency. So XX DSD for a pediatrician, the first thing is to exclude the life-threatening congenital adrenal hyperplasia. Then there are other rarer causes like aromatase deficiency and gonadal dysgenesis. Now, XY DSD means a boy who is either not having the gonads or the testis is not being produced or the testosterone is not acting. So they will have a gonad which is there, but the uterus will be absent because AMH is working. You will have gonadal dysgenesis or impaired effect of testosterone. And finally, we can have complicated disorders in which you have got both ovary, testis, ovotestis. So you will have got both testis and Mullerian structure. So if you really want to classify DSD, all you have to look at is to see for a palpable gonad and go for an ultrasound to look for Mullerian structure. If you have got only Mullerian structure and no gonad, this is XX DSD. You look at CAH, most important cause. If you have got only gonad and you got no uterus, this is XY DSD. Difficult scenario. I'll talk a bit about in terms of approach. If you have got both gonad as well as Mullerian structure, this is again a complicated scenario like ovotesticular DSD. And if you have got nothing, no gonads, no Mullerian structure, it basically means that you're dealing with a scenario where AMH was there and the testis has vanished. So anorchia can become an important scenario. Karyotype is of course important, but it often takes some time. You should always have a large number of metaphase plates. If required, go for gonadal karyotypes and FISH for rapid test may be required. In terms of laboratory assessment, the most important investigation is 17-hydroxyprogesterone. So if you have a child who has got ambiguous genitalia, DSD with non-palpable gonad, go for 17-OHP definitely after 72 hours. And if the levels are high, you have to think of CAH. If you have got a low level of DHEAS, this indicates a combined biosynthetic defects. And then, of course, androstenedione, testosterone, and DHT will help you classify the XY-DSD from that perspective. And AMH, as I mentioned, is a marker of Sertoli cell function and whether the testis is there or not from that perspective. HCG test is an important test which helps us classify the various aspects. It is done if the child is after mini puberty and you assess the testosterone and DHT after HCG to classify these in terms of diagnosis. Now, if you look at XX-DSD, so we have got a girl who has got uterus, but there are no gonads. The most important investigation is 17-OHP. If 17-OHP is very high, you're dealing with 21-hydroxylase deficiency. If you have got a very high DHEAS, you are most likely dealing with a 3-beta HSD. And if you've got very high DOC level, you are basically dealing with a possibility of 11-dehydroxylase deficiency. Similarly, for XY-DSD, the main investigations are DHEAS, androstenedione, testosterone, and DHT. If all metabolites are low, we are dealing with a star or a side chain cleavage defect. If you have got a particular scenario in which DHEAS is high, you're dealing with a 3-beta HSD scenario. While if you have got a high androstenedione, this is 17-beta HSD, high testosterone, it's 5-alpha reductase, and high levels of Paul is androgen insensitivity. So if you do basic biochemical workup, you will get the right diagnosis in terms of assessment and evaluation. So the approach as far as DSD is concerned is to look at palpable gonads. And essentially, if you have got the palpable gonads, from there you can do the workup and give you a diagnosis. If you have got palpable gonads which are not there and Mullerian structure is present, this is most likely CAH. Your workup doesn't need to be, you do a 17-OHP, you'll get a diagnosis. Rarely you may have aromatase deficiency. If you have got palpable gonads and Mullerian structure, you are dealing with either gonadal dysgenesis, over-testicular DSD, or rare AMH problems. The confusion happens when there is a palpable gonad and there is no Mullerian structure, which is a XY-DSD. So here you look at testosterone levels. If your testosterone levels are low and you have salt wasting, you're dealing with those proximal defects which are there. If you're dealing with hypertension, you have 17-hydroxylase defect. If the salt status is normal, you're looking at a LHCG receptor or 17-beta HSD defect. If the testosterone is high, you look at DHT levels. If the DHT is low, it is 5-alpha reductase, and if it's high, it is androgen insensitivity. So looking at the palpable gonad, the Mullerian structure, 17-OHP, testosterone, you will get the diagnosis in most cases. So we'll quickly go through a few cases. This is a day 3 child who has PRADA4 with no gonads which are there. And what you are seeing here is that there is uterus present. So this is a XX-DSD. This is a case you should always be aware of. This is most likely 21-hydroxylase deficiency. You need to do electrolytes, which shows hyponatremia, hyperkalemia, and a high 17-OHP level. So this was a classical case of 21-hydroxylase deficiency. Another child who has again got similar features. There are uterus present, so XX-DSD, but the child doesn't have any salt wasting. 17-OHP is normal. Then you start thinking of other causes. And the most important scenario in that setting would be maternal virilization, which pointed towards aromatase deficiency. So again, a rarer cause to look at. Again, a child with bilateral gonads there, similar appearance, but there is no uterus. So we are dealing with a scenario which goes more in favor of a XY-DSD. In this scenario, if you look at testosterone levels were low and there was salt wasting. So again, this looks like a rarer variant of CAH, and this turned out to be a 3-beta HSD defect. So if we do a proper evaluation, we would be able to reach the right diagnosis of DSD. We have developed a DSD interpreter, which basically uses these basic tools to guide a cost-effective way of evaluating and assessing that. And we have found this to be highly concordant with clinical diagnosis in terms of assessment and management. So this was about the three important conditions I talked about in terms of growth hormone evaluation, pubertal evaluation, and DSD. Dr. Amanath, do you want me to continue for another 5 minutes to cover adrenal, or do you think we can close it because we were running a bit late on time anyways? Yeah.
Sir, please continue, sir, because as short as possible, 5 minutes, please complete.
Yeah. So because the time was less, I thought we can maybe cut on that, but I think we'll quickly go through adrenals, which are very, very important part to assess. So when you're looking at adrenals, it has got three specific zones. You have got zona glomerulosa, which produces aldosterone, fasciculata, which produces cortisol, and reticularis, which produces DHEAS. Now, aldosterone problems, if they are too much, you will have hypertension, hypokalemia, and alkalosis. If you have got deficiency of aldosterone, you will have hypotension and salt wasting. If your cortisol is high, you will have Cushing syndrome, obesity with short stature. If it's too little, you will have lethargy, weakness, hyponatremia, hypokalemia, and adenocortical insufficiency. And if you have got too much DHEAS, you will have early puberty and virilization. These are the settings you have to evaluate. I'll quickly go through the key aspects of adrenal evaluation. So the key test to look at is cortisol. Now remember, cortisol has got a definite diurnal rhythm. So levels will be highest in the morning. So if you want to assess for deficiency, you look it in the morning, and the levels are lowest in the night time. And if the levels are high at night time, this suggests this is Cushing's. So if you want to look for Cushing's, look at the midnight sample. If you look for adrenal insufficiency, go for the morning sample. And always look cortisol along with ACTH, which should be done also in an 8 a.m. sample and immediately sent on a frozen one. Remember, there's a log linear relationship between cortisol and ACTH. If your cortisol is low, your ACTH should be really high. This is adrenocortical insufficiency. If ACTH is low or even normal, this is a central cause. If your cortisol is high, your ACTH should be really low, which basically is ACTH independent. If your ACTH is high, you're dealing with a ACTH dependent Cushing's disease in that regards. So in adrenal insufficiency, if you want to evaluate, you are basically going to look at levels of cortisol. If the levels of cortisol are low, you are most likely dealing with adrenal insufficiency, but low cortisol alone are not good enough unless you have got a high ACTH or there is a hyponatremia, pigmentation, or salt wasting. The other way to look for in terms of evaluation is to give a ACTH injection, in which you can give a high dose, which is 250 micrograms, or a lower dose ACTH and see how much the cortisol rises. If the cortisol does not rise, it is suggested that you're dealing with adrenal insufficiency. You can also use insulin, which causes hypoglycemia, and glucagon as a stimulation test. So key message is, unless you have a sick child who has got a low cortisol, you cannot make a diagnosis of adrenal insufficiency. Go for a stimulation test, go for a dynamic test, which becomes very, very important from that regards. A few words about infancy. In infancy, you would definitely have confusion because levels are lower. So you need to use lower cutoffs in infancy to identify adrenal insufficiency. And very importantly, these individuals will have a lot of fetal adrenals. So you should use an extracted sample using structured assays. So key message, if you're diagnosing cortisol deficiency in an infant, be cautious. Consult an endocrinologist because that may have huge long-term implications. Now, finally, if we talk about Cushing syndrome, this is a scenario in which your cortisol levels are high. You basically have to look at, again, the curve. The options are to look at the diurnal rhythm, which we don't do now very often because there could be a lot of confusions there. The ones which we tend to use is to use either a urinary excretion, which often becomes cumbersome, but it's a good test to look at, the 24-hour urinary free cortisol, which is the good marker. Or we look at a midnight cortisol, which gives you a level. If it's high, it suggests that this is most likely to be a Cushing syndrome. The other option is to give an overnight dexamethasone suppression test, which will decrease the cortisol level. And if the cortisol level do not decrease, it is suggestive of significantly high levels in that regards. So in terms of adrenal assessment or any form of endocrine assessment, what you have to look at is to look at the basal level, but often basal levels may be confusing. So you should go ahead in contextual assessment as well as in terms of the dynamic test, which may be stimulatory or inhibitory depending on the condition. So this was an extensive talk, I think, because we are trying to cover a lot of topics, especially with regards to starting from growth to puberty to DSD and then to adrenal. So we have tried to cover a lot of them. Many of these resources are also available in my YouTube videos, which you can go and have a look at it, or the website. So thanks, Dr. Amarnath, Dr. Jaivinder, Dr. Raghupati, for this wonderful opportunity, and all people for patient hearing.
Thank you so much, sir. We have covered a lot. We request you to bless all our students and our team. And that was an excellent presentation and discussion and in stipulated time. Thank you, sir.
Thank you. Thank you.
Now I request Dr. Atul. Sir is a pediatric endocrinologist from PGMIR.
Yes, sir. We can start, sir. I think
Yes,
screen
please.
I've sent it to Ankit. So Ankit,
Yeah.
if you can see the screen, that should be okay.
Should I share that?
Yes.
See, if my screen is not visible, so I think you should start sharing.
It's visible, sir.
It's visible.
Yeah.
Okay.
Yeah.
Dr.
Please go
Amarnath,
ahead.
sound,
Yeah.
voice is
Yeah. Excellent. Excellent. Please go ahead. So first pediatric endocrinologist with DM from PGMIR.
So, coming to the first slide. Okay, coming to the first slide. This is the determinants of total body energy as we were discussing. So it tells us basically that if we are eating, it definitely accumulates, and physical exertion and basal metabolism, these are the only two ways, and non-exercise activity thermogenesis, and diet-induced thermogenesis, which causes decrease in the weight, that is utilization of the energy. So coming to factors in obesity, now we know that there is intrauterine programming. So small for gestational age status should be known, the formula rather than breastfeeding in infancy, and there should be an early introduction of proteins in infants' dietary intake. So intrauterine programming becomes more important when we see patients coming up with lots and lots of obesity, and we need to know that at what age it has particularly started. So definitely mothers with hypertension, mothers with thyroid disorders, and definitely with the type 2 diabetes, they have some sort of intrauterine programming which causes the obesity in the siblings. The second thing is there are multiple factors, like individual factors like intrauterine environment, parental factors, ethnicity, genetics, sleep, diet, and physical, which are the individual factors responsible for obesity. Secondly, there are socioeconomic factors like parental employments, education, household, and community factors like housing, school, and literacy. Now, we all know because of excess food and industrialization, the availability of food has increased throughout the world, most of the part of the world. So therefore, we see that when there is excess food, definitely there is increase in amount of obesity world over. And third thing is the thrifty gene hypothesis, where there is increase in the obesity because of thrifty genes present. So coming to the next part, that is the little bit animations. So we see that Jerry is always hungry. He sometimes takes foods, and he's definitely having lots and lots of food. So sometimes he also steals food, and this is what Jerry has become. So it's a typical case of exogenous obesity, where the person eats lots and lots of food and grows fat. So that is a very simplified example through Jerry, but I think was the most common cartoon we all see. And monogenic obesity differentiated, we can, because if it is early onset, then definitely it becomes monogenic. So through this photographs, we can just assess both the conditions in one go. Second thing is that we find that if Jerry is hungry, what is happening is he needs food. If he needs food, there is a sort of energy balance which is deficit. The food is decreased and energy, it is also decreased. So what happens is there is ghrelin which is secreted from the stomach, and it goes along inducing the second order neurons, that is orexigenic response or hunger. And it is a sympathetic response. It induces sympathetic response, which causes the person to hunt for food. It is through the NRP and agouti-related protein pathway in the arcuate nucleus which causes all these things. The second thing is, now the Jerry found food. So this was the milk which he consumed, and he has developed satiety. So whatever secreted is insulin, leptin, PYY, PP, GLP-1, and all these, they basically are satiety peptides, and they also induce the adiposity signal. So in this case, we can see that there is food has increased and energy levels have also gone up. So these are the two conditions which we need to decipher, and this is basically the pathway of hunger. So this is the parasympathetic response here, where he is lying down and he's enjoying and digesting his food. So coming to the next part, exogenous and endogenous, as Dr. Anurag sir has very nicely told during his when the case was being discussed. So we shouldn't put much emphasis now on this part because time is running short. But definitely, if it is the onset is after 5 to 6 years, it goes in favor of exogenous. And if it is early, then it goes towards the favor of endogenous. So coming to the etiology, definitely exogenous and endogenous. And there can be, we know that exogenous has a chronic imbalance between energy intake. There can be monogenic causes, for example, melanocortin 4 receptors, leptin receptor defects, and POMC defects. Genetic syndromes, all these overgrowth syndromes are present. Elstrom, Bardet-Biedl, PWS, Beckwith-Weidman, Carpenter-Cohen, Albrecht hereditary osteodystrophy, and Rohat-Net syndromes. And definitely endocrine causes like hypothyroidism, Cushing, and multiple other causes. So this is how we, in this algorithm, we just try to see the patient where it falls. Now question comes, what to do? Thing is that whenever we go ahead, we see that who will help the patient. First thing is, patient and family in partnership with a multidisciplinary treatment team is required. Whenever we find or we diagnose the case, what is required is health education and skill building on multiple topics like behavior modification and counseling. It is definitely to be done in the healthcare settings or community-based settings with linkage. The dosage, we always say about doses. So it is a longitudinal treatment across around 3 to 12 months. That means approximately 1 year. And minimal sessions required are around 4 to 6, with increase up till more than 26 contact hours in 1 year. So the format is by group, individual, or both. And definitely they can be face-to-face, which has the strongest evidence. But definitely, since we are also on the virtual platform these days, it is also growing. So we need to have all these things. So coming to the food.
Sir, can you be short, sir? We have very less time. Be short. Yeah.
That's it. So definitely we have to give a plate formula where we put in the food, 45% of carbohydrate, around 20 to 30% proteins, rest of fats. And it is a food pyramid, which definitely we need to know how the things can be given with low calorie. And this is a traffic signal system where we have to stop with certain foods and where we have to go ahead with the foods which can decrease the amount of calorie intake by the patient. So body structural functions, definitely it is recommended around 60 minutes of activity per day. And we should avoid the sedentary activities. We have to have participation with friend circles. There should be environmental factors with the family and personal factors also, which involve having fun, outdoor activities, all these things. So these are the drugs which have been thought about and they are all FDA approved over a period of time. Definitely the role comes after 6 months, as we have already discussed, and we need to give them if we are not able to get across with all the activities and whatever we have told the patient to do, including diet and the exercises. So that is the last slide.
Yeah.
Thank you, everyone.
Yeah, thank you very much, sir. Sorry for the inconvenience. And sir has told very nicely, and it's applicable to us also. It's a social disease. Like Professor used to say, Dr. Raghupathi sir.
Dr. Amar, your voice has lot of echoes.
Okay. So, can you go next, please?
Hello?
Yeah.
Now
Sir, Dr.
Sir,
Ashish.
actually your voice
Okay.
breaking. We are not.
Now you are able to listen?
Sir, we are not able to hear clearly, sir.
Okay, okay. Can you ask Dr. Ashish to continue? Yeah.
Dr. Should we proceed for the next next thing? Oski?
Yeah. Go ahead.
Now I invite Dr. Ashish to present the Oski session for the students. So Dr. Ashish is assistant professor at Sri Guru Ram Rai Institute of Medical and Health Sciences, Dehradun, Uttarakhand. So Dr. Ashish, please present your Oski.
Thank you, sir. Thank you, the PEP team, to giving me for this opportunity of the OSCE session. My work has already been done by all the stalwarts, Dr. Anurag Vajpayee sir and Dr. Vaman sir. They have already told all the things which I'm going to ask in this OSCE session. So I think all the panelists, the few of the PGs which are here in this session, they'll be able to answer it very fastly. I have tried to keep the questions very easy. So I'll wait for 10 to 20 seconds for each answers, because we have short of time. So I'll just read the question and then wait for answer for, request to the PGs to kindly speak up the answers a little quickly, so we can be on time. So the first question, the first OSCE is 11-year-old girl was evaluated for excessive body weight. Mother 45 years of age, father is 50 years of age, have recently diagnosed with obesity, dyslipidemia and type 2 diabetes, and they are worried about their daughter. So there is a history of sedentary lifestyle. On examination, she had a weight of 65 kg and height of 150 centimeter. She had hyperpigmentation of axilla, groin and neck regions. So what is the body mass index of the child? How would you classify as per IEP 2015 BMI charts? What does pigmentation denote? How do you classify class 2, class 3 obesity? And which common complication evaluation is necessary in this child? PG.
The BMI.
Yeah.
So the BMI is 28.8, and it is greater than 27 adult equivalent. So she is obese, and pigmentation denotes acanthosis nigricans. So class 2 obesity is so greater than between 120% and 140% of 27th adult variant, and class 3 is more than 140% of 27 adult variant.
Yeah. So you're absolutely right. And what are the complications which we should do the screening for at least?
Dyslipidemia,
type 2 diabetes mellitus, hypertension.
Yeah. So what you have done in your cases also. And so moving on to the second question. A 3-year-old male child presented with complaints of excessive weight gain since last 18 months and hypogonadism. Child was a product of non-consanguineous marriage with birth weight of 1.2 kg, had history of feeding difficulties initially, and developmental delay is present. On examination, child's current weight is 22.3 kgs and height is 90 centimeter. So this is the picture of the child. So what is your diagnosis? What is the genetic defect? And name 3 other features of this particular diagnosis.
So this is Prader-Willi syndrome.
And what is the genetic defect?
So this is due to 15q11 defect, gene defect.
So 15q11-13 deletion. And other features associated, you all know, obesity, hyperphagia, growth retardation.
Yes, sir.
So moving to the third question, 4-month-old female child presented with excessive weight gain, birth history revealed term AGA child born to non-consanguineous parents. Parents also gave a history of diaper and intertrigo rash for which they are using a topical cream. On examination, weight is 11 kg while the length was 63 centimeter. So this is the child over here in the picture. Identify the 2 features which is giving clues related to the pathology.
Sir, moon faces.
Yeah.
Excessive hairs.
Yeah, good. And on investigation, cortisol was found to be low. So what is it telling us? What is the diagnosis?
Sir, Cushing syndrome.
Yeah, you are right. So name other features which is associated with this pathology.
Sir,
You know
abdominal
all the
striatum.
abdominal stria and all the other features
sir.
which are there. You
Buffalo
need
hump.
to name them. Yeah.
Yes, sir.
So moving to OSCE 4, a 5-year-old girl, a child presents with a history of vaginal bleeding, 2 episodes over the past 5 months. On examination, breast tenor stage 3. Patient has few hyperpigmented lesions with irregular margins over chest and back. What blood test we would do in this child? What is the diagnosis? And what is the genetic abnormality? And what are the associated other features seen in this condition? So this is the child. And if the mark is visible, so this is this mark which is there in this child. So what is the diagnosis?
The McCune-Bread syndrome.
Very good. What are the
syndrome.
investigation that you will do to confirm this?
The LHF,
Bone age can be
extradiol,
done. USG whole abdomen can be done.
bone age.
Yeah, and so what is the triad? What is the mutation? The third question.
GNS
GNAS mutation. The activating missense mutation of GNAS.
Yes, good. And the last question was, what is the triad and what is the associated other things which you can see here?
So triad is precocious puberty, hyperpigmentation, and polyostotic fibrous dysplasia.
Yes, good. And other glands activation can be there, such as hyperthyroidism, acromegaly. Good. So moving on to the 5th OSCE. A 3-year-old boy presents with history of progressive penile enlargement over the last 2 years. Stretch penile length is 6.5 centimeter. Testicular volume is 2 ml bilaterally. Parents gave a history of elder sibling death at the age of 10 years who had similar complaints from the age of 2 years. On examination, patient also found to have hypertension. On further investigation, patient had hypokalemia, low cortisol, low aldosterone, high ACTH, high renin, increased testosterone, and prepubertal LHFSH. So what is the probable underlying enzyme defect? What biochemical findings will suggest this condition? And what is the treatment which will be offered here?
Sir, this is due to maybe 11 beta hydroxylase.
So you're
Sir,
right. So this is a
11
case
beta.
of pseudo-precocious puberty with apparent mineralocorticoid axis and with increased testosterone. So the diagnosis becomes 11 beta hydroxylase deficiency. So this is the pathway. I'll not go into the details of the pathway where is the blockage here and causing this problem. So the treatment is hydrocortisone along with a
And
potassium
amiloride.
diuretic. So 6th OSCE, 3-week-old boy born of 3rd consanguinity present with persistent vomiting with increased lethargy. On examination, he was dehydrated and unwell. His systemic examination was otherwise normal. Septic screen was negative. Urea creat normal. Hemoglobin 16. Sodium 115. Hyponatremia with hyperkalemia. Potassium 6.5. And blood sugar of 90 with the low cortisol. So what is the diagnosis here?
It's a case of CH.
Good. So what is the investigation that we will do to confirm the diagnosis?
The 17 OHP.
And what is the mode of inheritance of this disorder?
Autosomal recessive, sir.
Yeah, good. So a week-old neonate presented to OPD with a small phallic structure, 2 centimeter, and non-palpable testis bilaterally. So would you label this child DSD?
Yes.
Yes.
So what apparent male genitalia conditions that warrants DSD investigation, and what will be the initial steps of investigation?
So palace less than 2.5 centimeters. Actoromegaly in girls, if in case of a girl.
So the DSD conditions, as you are saying, right? So in terms of these are the conditions where you need to warrant the DSD investigations. Male non-palpable testis, isolated perineoscrotal hypospadias, severe hypospadias, undescended testis, and micropenis. And the initial investigation is karyotype and USG pelvis. So this is the approach, as Dr. Anurag Vajpayee sir has already described in detail about the approach. Not go into these things. So moving on to the 8th question. What are the different methods of bone age calculation? Name any three.
Sir, Tanner Whitehouse method,
The Grulich pile and
bone expert,
bone expert.
expert automated method.
Yes, very good. Which X-ray is needed for bone age assessment in children?
sir,
Left wrist
hand
with
and
hand.
Left hand and wrist.
PA view.
And what are the three causes of a delayed bone age?
The growth hormone deficiency, hypothyroidism,
Hypothyroidism,
and Cushing syndrome.
Parathyroidism.
And what are the three causes of advanced bone age?
So precocious puberty, obesity, and hyperthyroidism.
Hyperthyroid.
So next OSCE is 3.5-year-old boy was brought with history of bowing of lower limbs and breast widening. 1 year back, he had serum calcium of 8 milligram, phosphorus of 3.1, alkaline phosphatase very high of 3000. He received 6 lakh unit of vitamin D twice and adequate calcium supplements. And this is the current X-ray. And on further evaluation, vitamin D is 30 nanogram per ml in the normal range, and 125 hydroxy vitamin D is 300 picogram, which is quite high. So what is the diagnosis?
Sir, vitamin
D resistant rickets.
dependent rickets. Sir, vitamin D dependent rickets.
So which type?
Type 2.
Type 2.
Type 2.
Type 2.
Yeah. And what is the scalp abnormality which will be present here?
Craniotabes. Craniotabes.
Yes. And
Craniotabes, alopecia.
yeah. And what are the doses? Is calcitriol in high dose, and assessment will be monthly assessment of serum calcium, phosphorus, alkaline phosphatase, and calcium secretion, calcium create ratio. So the next one. A 17-year-old girl with normal breast development was brought with primary amenorrhea. External genitalia showed the presence of inguinal swelling, consists of a firm oval mass on the right side. On ultrasound scanning, uterus and ovaries were not detected. So what is the likely diagnosis?
Congenital
Sir,
testosterone
androgen insensitivity syndrome.
Yeah, it's complete androgen insensitivity syndrome. So what do you expect the karyotype to be?
XY.
Why?
And which hormonal test would you do, and what result do you expect?
Testosterone levels, they would be increased and LH would be decreased.
LH levels, yes, sir.
So moving on to OSCE 11, a 9-year-old boy presented with generalized weakness, lethargy, fatigue since past 4 to 5 months. Parents also noticed child developing hyperpigmentation all over body. Child presented to emergency with complaints of vomiting since 1 day and brought with hypotensive shock. So what is the diagnosis? This is the picture of the child.
So this is a case of adrenal insufficiency.
Yes, so primary adrenal insufficiency. So what is the gold standard test to confirm your diagnosis?
So ACTH stimulation test.
Syntropin test.
Yeah, synectin stimulation or ACTH stimulation test basically. So what is the triad of autoimmune polyglandular syndrome type 1?
The mucocutaneous candidiasis, so hypoparathyroidism and adrenal insufficiency.
Yes, so you are right. Hypoparathyroidism and adrenal insufficiency along with chronic mucocutaneous candidiasis. An otherwise asymptomatic 3-year-old female brought for evaluation of short stature. Her height is 80 centimeter, upper segment is 50 centimeter, head circumference is 51 centimeter. Proximal part of the upper and lower limb are shortened in comparison to distal part. The face is mildly dysmorphic with mid-facial hypoplasia. So what is the upper segment, lower segment ratio in this case? I'll tell you again, 80 centimeter is the height and upper segment is 50 centimeter.
Approx
1.6.
Yeah. So, and what is the expected upper segment, lower segment ratio at this age?
So 1.3 is to 1.
So you know it's so what is your likely diagnosis?
Achondroplasia.
What is the genetic defect?
So there is fibroblast growth,
Defect
in fibroblast growth factor.
FGFR3 gene mutation. And what do you see in the X-ray over here?
The first is right hand.
Yes, and in the X-ray?
round
round
iliac bones
iliac bone.
and flat acetabulum roof.
Yeah. So flat as superior acetabular roof and short round iliac bone. So next OSCE, an asymptomatic 11-year-old girl is brought by her mother with the concern that she is not growing adequately as compared to peers. She estimates that the child has grown less than 2 centimeters in past 6 months. There is no significant past medical illness or family history of disease. She is scholastically average, psychologically well adjusted. Father is 170 centimeter, mother is 160 centimeter. Physical examination revealed prepubertal with no clinical abnormality, and her height is 123 centimeter and weight is 28 kgs. So you need a growth chart for this. If you have the growth chart with you, can calculate the weightage, heightage, and target height for this child. So if you don't have the growth chart, we can move on. I'll just show you the growth chart part over here. So this is the weightage and heightage of this child. 9.3 years is the weightage and heightage is 7.9 years and target height is 158.5 centimeter. So the next question is, what is the basic investigation that you would like to do in to further assessment?
Complete hemogram,
Thyroid profile,
karyotyping, RFT, LFT,
Bone
urine
age.
examination.
So just remember to not miss the karyotyping here. It's a female child. And had this been a growth hormone deficiency, what clinical findings you would have looked for?
Infantile faces, doll-like.
Chubby appearance.
Yes. Last question, sorry, 14th question. A 7-year, 3-month-old male child brought by the parents with complaints of not gaining height as compared to peers since last 3 years. On examination, child has infantile faces with height of 103 centimeter, weight is 24 kg, mother's height is 157 and father's height is 170 centimeter. Parents have already got a baseline profile done, which is showing CBC, LFT, KFT, thyroid profile, TTG, and cortisol is normal. Bone age is 5 years. So what is your provisional diagnosis? Again, you need a growth chart to plot the weightage and heightage. So if you have the growth chart, you can plot it easily. So what is the provisional diagnosis? I'll show you the parameters again. So height is 103 and weight is 103 centimeter at 7 years, 3 months of age with weight 24 kgs with a bone age of 5 years.
so maybe growth hormone deficiency.
Yes, so the height age is more affected than the weight age, and bone age is also affected. So yes, growth hormone deficiency. So which test is to be undertaken for this child?
Growth hormone stimulation.
So maybe
so what are the
glucagon.
Yes, so as we just discussed in the last session.
Yes, sir.
And so what is the growth hormone cutoff for provocative test?
Less than 7 nanogram per ml.
Yes, as per the current guidelines, is less than 7 nanogram per ml. And a random growth hormone sample is sent in a different patient, in a neonate, on 5th day of life with suspected congenital growth hormone deficiency, revealing growth hormone of 4 nanogram per ml. So does this random sample in a neonate of on 5th day of life confirm the GHD, or it does not have any value?
But in neonate, if it is less than
Sir,
7,
it is not confirmed.
which reveals it is suggestive of deficiency.
Yes, we just discussed in the neonate in the first week of life, it does confirm the growth hormone deficiency. There are few areas where provocative testing is not always required. This is one of the area. So this is my last OSCE of this session. So Ishita, a 7-year-old female child, belongs to well-educated family, weight 18 kg, diagnosed type 1 diabetes 1 week back. She started on insulin glargine 9 units and Novarapid 4 units with each meal. She's having high morning fasting sugars. Parents just learned about CGMS and started using. And this is the CGMS graph that they are showing. So with this graph, what is the reason of high blood sugars in the morning? What is this phenomena called? So I'll tell you a little bit detail. So this is the first line is 12 o'clock midnight, and over here some then you're again you have somewhere at the end 12 starting from 12 midnight to 12 midnight. This is how this CGMS chart is shown here. The timing is not written here, that's why I'm telling you. And red represents the hypos and the yellow represent the hyper, and this gray zone is the normal values between 80 to 140. So what is the cause of morning fasting high sugars here?
The Sumogi effect because of tight
Yes,
sugar
very
control.
good. So what do so the next question is, what will you do to correct this thing? What is the change you'll do over here?
So decrease night
Glargine dose.
dosage.
Yes, so decrease the basal insulin. The last question is, how can you improve her glycemic control further?
through lifestyle changes, sir.
So we'll teach her carb countings.
Yes,
as-
very good. So we'll teach them about the carb. As this is an educated family, you can definitely try teaching them about the carb counting, correction doses, and other things related to the type 1 diabetes. So with this, I'll be ending my session. And
Yeah, thank you very much, Dr. Ashish.
I think I was on time, so I tried to go little
Yeah. Thank you so much. And first time we are seeing so much of coordination between the teacher and students. We congratulate Dr. Ashish and also Dr. Atul for doing tireless work.
So
just 1 or 2 minutes.
Job was simpled by Dr. Anurag sir and Dr. Vaman sir. They have already told all the answers in their presentations.
Yeah, more than that, your students are very much active even in the last minutes. Just we'll go through just 1 or 2 minutes about the question and answers. Just questions I'm going through. So please note. So commonly asked questions in this area. So I wanted to tell just 1 minute. We have to prepare both theory and practical, very important in especially in DNB. DNB most important is your clinical case presentation, 50% marks as an examiner and 50% for the demonstration. So please spend time with the patient. Please spend time with the at the bedside and learn from the patient's maximum. Okay, don't spend more time with your mobiles and your books. So we'll conclude within 1 or 2 minutes. Short stature, what are the questions? Already it has been covered. Failure to thrive, short stature, dwarfism, factors stimulating, inhibiting secretion of growth hormone. This is very, very important because fasting and exercise will increase the growth hormone. Bone age assessment already covered, and investigations of hypopituitarism, MRI pituitary already has been told. Also the investigating the other hormones like thyroid hormone and cortisol before going for the growth hormone assessment. Approach to tall stature, approach to obese child, thyroid gland, most commonly asked newborn screening. They are asking newborn screening. So don't forget, read about that, most important thing. Interpretation of thyroid function test. You should know hyperthyroidism, hypothyroidism, TBG deficiency, euthyroid goiter, like that. So briefly list various thyroid function tests. You should know about the technetium 99 scan and ultrasound with Doppler. So most important, don't forget about the ultrasound with Doppler. So you can detect the ectopic thyroid. So management of Hashimoto thyroiditis, you should know anti-thyroglobulin antibodies and anti-thyroid peroxide antibodies. Below 3 years, no need of antibodies. More than 3 years, you do antibodies. So if antibodies are negative, then you go for ultrasound thyroid. So investigation of for the goiter. Next is the for the DSD, and 14 years child with infantile genitalia should look for growth hormone deficiency and also delayed puberty, that is the hypogonadism. Then how will you manage the case of virilization? This is case of CAH commonly asked. Don't forget diagnostic approach to precocious puberty in girls and boys. So you should look at the question properly. Sometimes you are writing both, don't write. So focus whenever they ask for only girls, right?
only girls, and preferably put the flow charts like biochemical testing, radiological testing, like that, and bone age assessment. Next, electrolytes. This area is very commonly missed. So, as sir mentioned, diabetes insipidus, SIADH, Bartter syndrome, Gitelman syndrome, approach to case of polyuria and polydipsia, renal tubular acidosis. Commonly asked question. Don't forget that adrenal glands, adrenal crisis is most commonly asked, apart from the Addison's disease and CAH. So diabetes, they are asking last 2 times CGM. So HbA1c is now outdated, means they are using, but most commonly time in range, that is TIR. Normally it varies from 60 to 80%. If you take 24 hours time, so time in range, they may ask in this thing. So please go through continuous glucose monitoring. So management of type 1 diabetes, what are the investigation you should do? You should read that. And regarding the calcium, most commonly asked are about the hypoparathyroidism and pseudo hypoparathyroidism differences, and approach to hypercalcemia and hypocalcemia along with vitamin D guidelines. So these are the commonly asked questions. This ends the theory questions. Now hand it over to Jaivinder ji and to Raghupati sir.
Thank you, Amar. Thank you, everyone. Thank you, Dr. Atul, Dr. Ashish, Dr. Vaman, Dr. Anurag, Raghupati sir, Dr. Amar, for the tireless efforts to make this session a very successful session. And we have around 180 audience which has joined us for the session. Now I hand over to Professor Raghupati for the last words for the session.
I hope all the postgraduates learned a few details about endocrinology, and we had very good session, and especially the OSCE one. But I wish we had more time and we could give a little time for them to digest all the things. And I must also thank Dr. Jaivinder for sharing the responsibility with Amarnath, and he's happy that there is some burden off his shoulders. And thank you, Dr. Jaivinder, for helping Amarnath and for the conduct of this program. I thank everybody and for the continued patronage from ISPAE, Dr. Haila also. And thank you very much. And I hope all of you enjoyed today's session. Thank you.
Good night. Thank you, sir. Thank you, everyone. Bye.
Thank you, sir. Thank you very much.
We thank all the students for active participation, especially in the ASCII. Thank you so much. We thank RX Events for conducting excellently, and especially team Himachal Pradesh and Uttarakhand. Victory to you. Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you.
I think we can end. Ankit, thank you.
Thank you, sir. Thank you. Good night.
Thank you.